heavy menstrual bleeding and size of uterine fibroids, and we have hormonal and non-hormonal treatment. Considering the hormonal treatment, the GnRH analogs and the SPRMS that are older, and more recently the introduction of oral GnRH antagonists. The old agonists they reduce the risk of recurrence after surgery, but as we know, they have limited use for the hypoestrogenism with loss of bone mineral density and presence of vasomotor symptoms, the presence of the initial flare-up effect, and for the compliance, most of the products are injectable. The ulipristal acetate, as we know, was effective for the treatment of women with symptomatic fibroids, but is characterized by several side effects and complications. So several countries has stopped its use. Finally, what about the oral GnRH antagonists? The first introduced in the clinical practice was the elagolix, followed by relugolix, and finally linzagolix. All these drugs are characterized by 4 advantages compared to GnRH agonist. In particular, the oral administration, the rapid reversibility of their effect, the absence of flare effect, and the dose-dependent partial or full estrogen suppression that may be reduced with the add of the advert therapy. So, these drugs are effective in reducing heavy menstrual bleeding, reducing pain, reducing uterine volume, and are well tolerated. Also because the introduction of added therapy reduces the risk of hypoestrogenic effect. In particular, relugolix is approved for the treatment of uterine fibroids, heavy menstrual bleeding, for up to 24 months. What is the management of uterine fibroids? We can see to the future, in a future in which obviously surgery and radiological procedure will maintain their importance, but the medical treatment may permit several advantages, in particular to treat symptoms, to prevent after surgical recurrence, to postpone or to avoid surgery, and in some cases to prevent occurrence in genetical predisposed women. So, long-term management of uterine fibroids may benefit from the medical treatment in all classes of age, in particular in young patients to bridge to the pregnancy, in case of mid-reproductive age for the first 24 months at the moment and following re-evaluation, and also in perimenopausal patients in order to bridge to the menopause. So, to conclude, uterine fibroids are characterized by an high recurrence rate associated with several factors. Conservative surgery and radiological procedure are excellent options, but they require a correct patient selection to reduce the risk of recurrence. The medical treatment, in particular GnRH antagonist, may be useful as long-term management to treat symptoms, to prevent recurrence, or to postpone and to avoid surgery. Thank you very much.
Thank you very much. That's an excellent talk, very elegant talk, and a great summary of where we're going, I think. We'd just like to ask maybe just one question, because we don't have so much time. Anybody would like to ask a question? It's very clear, your talk.
Thank you. I want to repeat that this is not so surgical and radiological procedure are very, very important, but they are to be integrated in the next future with medical treatment.
Thank you so much. I'd like to, my colleague will introduce the next speaker. Sorry, we've just switched the talks around, so we're doing the first talk of the session now.
The next speaker, Professor Mohammed Mabrouk from UK. Professor Dr. Mabrouk, he's a consultant gynecologist and minimal access reproductive surgeon with a special interest in endometriosis, advanced endoscopic surgery. Currently, he is co-director of the Cambridge Endometriosis Center, Cambridge University Hospital in UK.
You're presenting from yours. Is this yours?
This is ours, yeah, the events.
Dr. Mabrouk had two
management
talks
company.
now,
So
today.
share
The
your
first
presentation with
talk,
them to be-
he will address about the surgical
your
management
presentation?
of endometriosis
I'm
update.
presenting from my computer.
Oh, you
Professor
did, okay.
Mabrouk.
Oh, thank you very much for the kind presentation, and apologies if I came. Actually, I have been informed that there is a delay of 20 minutes, and this is why we were just outside. So apologies again for all of you. So today I have a difficult task to speak about surgery and endometriosis, especially after the fantastic lecture of Professor Kennedy, when he already said surgery for endometriosis is actually not that important. So I'll do my best to be as convincing as I can to speak about the surgery for endometriosis, especially the deep endometriosis. So who of you believes that obviously for the interest of time we'll not speak about ovarian endometriosis, we have already discussed this. So we will speak about deep endometriosis. And for deep endometriosis, let me start by a question. Who believes that surgery for deep endometriosis does have a space in the management of patients with endometriosis? At least yes. Okay, it has a space. Okay. And who believes that medical treatment alone can solve the problem of a patient with deep endometriosis? Oh, that's right. Voilà. Voilà. Non, voilà. Sorry for the technical issue. I've been promised that everything was fine. So لو مش شغال نخلي حد تاني يتكلم for the interest of time يعني عشان الوقت. تحت أمرك. So it seems that I have been in this situation before. But anyway, so let me just speak about it quickly. So for deep endometriosis, we'll speak about what deep endometriosis is, because it's not fair to speak about endometriosis as an ovarian cyst. Ovarian cysts is endometriosis of the ovary, but actually, oh, that's great, thank you. Okay. Okay, so we will speak about this. And again, for the interest of time, we will speak about deep endometriosis, and this is an update. These are my disclosures. And I would like to thank everyone for the kind invitation, but I also would like to thank my professors who taught me a lot of what I'll be saying to you here. And obviously, Dr. Ragat Mansour, who actually helped me to go abroad. And this is the agenda. And this is what I'm speaking about. So, let's start by defining what deep endometriosis is. And this is not my opinion. We know that there is a World Endometriosis Society for the definition of deep endometriosis. So, affecting an ovary is a variety, is one type of endometriosis. But actually, when the ovary is affected, this is purely affecting the ovary only in 15% of the cases. Really? Yes. Exacoustas et al. In 2018 made a big study, and they demonstrated that in 15% of the cases there is isolated endometriosis. In 85% of these cases, when there is endometriosis of the ovary, there is also endometriosis that's affecting the deep structures. And by definition, it is when the endometriosis goes underneath the peritoneum, by definition, academic definition, 5 millimeters. Many experts of endometriosis do not agree on that number because it can be 3 millimeters and affecting the nerves, and it's still deep endometriosis. Importantly, this is something that we know, we diagnose it preoperatively, so it's not that we go with the laparoscope, see something, and try to treat it. It is correlated to the severity of endometriosis, and it is also correlated to the complexity of the surgery, as we will see. There have been a lot of classifications about endometriosis, but this is more or less the anatomical classification that we believe in. And again, this scenario of an endometrioma that's easily diagnosed by ultrasound and easily managed surgically is not the everyday, this is the best case scenario, but actually this is the everyday practice. I'm sorry, but the movies are as expected due to internet connection. They are transmitting this through internet, and this is a bit slow, as you can see. But anyway, endometriosis can affect the nerves, as you can see here, can affect the bowel, and we need to do a bowel resection, segmental bowel resection, and it can affect the ureter, the parametrium, as we will see. So this is the everyday practice, and this is what we do in our endometriosis center. But then you come to ask me a question. Is there an evidence to support what you're doing? You are removing bowels, you're removing ureters, and you're doing very, very big surgery. And this is what Professor Kennedy said in the morning. Actually, we don't have a strong evidence to support this, and I have to be honest with you. There is no strong evidence to support it. And I'm sure you remember, and you know better than me, that this is the pyramid of the evidence, and these are the levels of evidence. And if you ask me, is there a strong evidence to support what you're doing in terms of surgery of deep endometriosis? And if we go to the Cochrane review, we will see Cochrane about everything. You will see Cochrane about acupuncture, herbal medicine, Chinese medicine, but you will not find an answer. Is there a strong evidence to support what we do in our surgeries, yes or no? And if you follow the guidance, the NICE guidelines in 2017 didn't give an answer to this. And so, as we've listened perfectly by Professor Kennedy in the morning, since 2005, ESHRI after ESHRI, and look here the wording, I totally agree. that in 2014, the recommendation was that it reduces pain. We can offer surgery because it reduces pain. 2022, the wording is different. 2022, it may reduce pain because this is the available evidence and this is what we have to base our practice on. And moreover, this paper from on the British Journal of Obstetrics and Gynecology in 2017, they compared national and international guidelines, and look at this. Among 152 recommendations, only 10, which is 7%, were comparable. So to conclude, yes, there is no strong evidence to support what we are doing in deep endometriosis management. Then, here I cite this. And we have to understand this disease a little bit more in depth. 2 + 2 = 4 in everything. But in endometriosis, when we speak about a strong evidence, we have to know that we are speaking about X plus Y plus Z, which equals. How can I randomize a patient with deep endometriosis? Selection bias. What deep endometriosis would I consider? Uterosacral ligament, rectovaginal, bowel, parametrium, and it is always a mixed disease. And this is why the concept here, and I'm very glad, and in my opinion, this is one of the best papers in management of endometriosis, is about value-based medicine in management of endometriosis. If we, as the example that was being discussed today, a patient with a 3 centimeter endometrioma, asymptomatic, not seeking a pregnancy, we are removing this endometrioma, yes or not? The answer is no. Confidently, yes, confidently. Why? Because this is a low-value care that we are offering to our patients. So what's the definition of low-value care? Low-value care is when we know that there is a definite harm for the procedure that we are doing, and we do it for a potential benefit. We know that removing this 3, there is a lot of evidence to support that this can reduce the ovarian reserve of this young lady. So why are we removing it? Because it might grow. Who said that? Because it can reduce, it can destroy the ovary. Who said that? Oh yes, because it may become malignant. Who said that? Who said that the lifetime risk of a malignant transformation of an endometrioma is higher in an endometriosis patient than a normal patient? So value-based medicine here, if we don't have a strong evidence of a high-level evidence, is important. And this is not a new disease. We have this paper since 1946. So we know about deep endometriosis. We have been treating it since many, many years. But again and again and again, we will not find, unless we find a possible way, and a massive fund today with Professor Kennedy. He was speaking about statins. Yes. I don't know, 80,000 patients? Yes. I'm not sure how we can randomize 80,000 patients to have a statistical significance with patients with endometriosis surgery against non-surgery. So, coming back to what we said in the morning, decision in endometriosis surgery is as difficult, as challenging as the surgery itself. Decision making is not easy. We are not treating lesions. We're not treating cysts. We're not treating nodules. We are treating patients. And the most important thing in this equation is the patient's objectives. The patient that has pain is different from the patient that has fertility issues. And as you can see here, it's a dilemma. Ultrasound is good, yes. You read it in the literature, yes. But it depends on who does the ultrasound. Eyes do not see what mind does not know. MRI is good, yes, but it depends on where you work and if the radiologist gives you the information that you need. Finally, diagnostic laparoscopy used to be the gold standard for diagnosing endometriosis. It is not, especially for deep endometriosis, and this is not only my opinion, this is the opinion of many experts of endometriosis. ESHRE 2022 removed laparoscopy as a gold standard for diagnosing endometriosis. So this is what we need to have. We need to have an algorithm in our brain. We have to think endometriosis. We have to understand the disease, but more importantly, we have to understand the patient's objectives, make a precise diagnosis, help the patient to make an informed choice. We give our patients as much information as we can, and we help the patient to make a good choice. And this is what we heard in the morning. What is the best management then? The best management is the management that takes the patient in the center, her objectives, and take a 360-degree approach, a holistic approach to the patient. Not only to her fertility, not only to her pain, but a 360 degrees approach. In deep endometriosis, we follow this, which is a site-specific approach, either anterior, lateral, or posterior, and technically or surgically, I will not take much of your time, but I would like just to focus on this. Why do we do surgery for endometriosis? To optimize pain, because patients with deep endometriosis, if medical treatment fails to improve their pain and quality of life, we have to operate on them. To optimize fertility, maybe if a patient with deep endometriosis has 2-3 failed IVF, then we maybe, if we offer her surgery, this would improve it. I'm not sure, I'm not a fertility specialist, but there are some absolute indications for surgery. A risk of kidney loss is an indication for surgery, subocclusive or occlusive bowel stenosis, and if there is a suspected malignancy. And with this, I would conclude with some important concepts. For deep endometriosis, we need to do one successful surgery. A surgery today to burn and ablate, and a surgery tomorrow to maybe burn again and ablate again, or after tomorrow. No, this patient deserves a good care, deserves one successful surgery. And it should be patient-oriented, not ego-oriented, and not lesion-oriented. Very important is the counseling to the patient and helping the patient to make an informed choice, and it's important to make a personalized counseling. With deep endometriosis, we don't have to counsel all the patients for the risk of stoma, for example. Why? Because not all the patients need a stoma. Many patients, we operate on them, and the risk of stoma is 2%. Here, another important concept is how radical we should be radical. So you're saying we have to remove and we have to be adequate. Yes, but we have to be as conservative as possible on the patient's organs and her functions and her nerves. Because as you can see here, nerve-sparing surgery, that's what we say to our patients. When I started to do endometriosis surgery 18 years ago, this was the specimen from the left colon for resection of the bowel for endometriosis. But in 2012, we published this paper on human reproduction where we analyzed the recurrence rate, anatomic recurrence, pain recurrence, and quality of life. And we realized that this specimen is not actually that important. If you excise 1 centimeter above and 1 centimeter below from the lesion, conservative radicality, and this is the concept of economic radicality, conservative radicality, all the less is the better. Nerve-sparing surgery is a very important concept, and I will just remind you, this paper by Marc Possover in 2012, that I've been privileged to be one of his students, the time between operating a patient and having an irreversible damage of her bladder is 9 years. So you operate on a patient today, and tomorrow, no. After 9 years, she might have an irreversible damage of her. And this is the concept. I've spent something like 10 years of my life with a team, my fantastic team in Bologna, to standardize a method about how to operate and how to do nerve-sparing surgery. And we published this, and there is a method that we published on the JMIG by studying cadavers and live patients to make a topography of where to find the autonomic nerves and how to identify them and how to do nerve-sparing surgery. So in conclusion, the last question about this type of surgery is, okay, where to operate these patients? And Professor Kennedy in the morning answered this very, very clearly. He said in endometriosis centers. An endometriosis center has to have an endometriosis specialist, Then comes the question, who is the endometriosis specialist? How shall we define the endometriosis specialist? Is it only his volume, years of experience, training, complications, etc., etc.? This is also a very important topic to consider in defining. Anyway, this is another interesting paper about endometriosis surgery, and it asks a very important question. Is it the song or the singer? Is it only a difficult surgery? Is it a difficult song? Or it's my voice that's not able to sing it? And yes, it is both. The surgery is complex, and the volume and training are very, very important. And it's not new. It's not a new concept. As you can see here, it's 2007, where in the Western world, we started in the UK since 2007 and 2013. And then there are endometriosis centers, as we heard in the morning, where they put the endometriosis patient in the center. And as you can see, all these are the healthcare professionals that do their best to provide this patient a holistic approach, starting from the endometriosis specialist, but more importantly, the endometriosis specialist nurse, fertility specialist, and all these. I'm proudly a director of one of these centers, and by this, I would like to thank you very much for your attention. Thank you.
Okay, thank you, Professor Dr. Mabrouk, for this excellent presentation. We can allow one question only for Dr. Mabrouk. Okay, Dr. Muhammad.
Yes. Sure.
Thank you very much for your interesting talk as usual. In the surgery, you put any barriers for re-adhesion or no?
If the question is a practical question, the answer is that if I have, I can. If I have them, I put them. If the question is a scientific one, there is no evidence to support the use of those. There are 2 weak studies that demonstrated that the use of barriers would help in preventing adhesions. And to prove this, I have to do a real laparoscopy for the patients, which is not ethical.
But as usual, we know, all of us know that endometriosis is a mystery journey without known etiology, known prognosis, ideal known treatment. What you are doing, especially for recurrent case?
Again, it is a matter of tailoring the management according to the patient. Managing a recurrent endometriosis in a 22 years old is different from a 49 years old. 22 years old with a desire of fertility is different from 22 without a desire of fertility. So it is, we have a lot of cards and a lot of options, and we have to tailor what we do, and it's not always surgery. Surgery, in my opinion, should be the last thing we resort to, but it has a space. When medical treatment fails, I refer many of my patients to IVF or egg freezing first. And again, this is not because I'm a good guy, this is because this is the evidence that we have.
شكرا.
أحترم.
ناخد second question. We are sorry, we are. Thank you very much, Professor Mabrouk. I'm proud of you, and I'm witnessing the wisdom of evolving practice. Actually, some of the heterogeneous conditions like endometriosis, it would be very difficult to stick that we should have an evidence. Tailoring and individualization is the ultimate message, and I thank you very much for your presentation. Now we move to next speaker, Professor Abdelhamid Ataya, Professor of Obstetrics and Gynecology, Cairo University. Personally, I enjoyed the presentations of Professor Abdelhamid. He is going to address us about non-resectoscopic techniques for endometrial ablation. So please.
Thank you very much, Mr. Chairman. Really, I'm very thankful for Professor Gamal Abu Surur and the organizing committee of the Congress for inviting me to discuss the topic of endometrial ablation non-resectoscopic techniques with the distinguished audience. Well, as you all know, endometrial ablation is a surgical procedure to destroy the endometrium with the aim of reducing menstrual flow. The primary indication is chronic anovulatory menorrhagia. Sometimes it is used in acute abnormal uterine bleeding in hemodynamically stable women when medical treatment is contraindicated or unsuccessful. We all know about the resectoscopic ablation devices, which are called the first generation devices for ablation, such as the roller ball ablation, the wire loop, and the laser. But these devices require high technical skills. They require general anesthesia. They take longer time in the operation, and they have a higher risk of complications as the fluid overload or hematometra. Currently, there are non-resectoscopic ablation devices, which are called the second generation devices. They require less specialized training and shorter operation time. Currently, it is more widely practiced than the resectoscopic ablation and is done with a device that is inserted into the uterine cavity to deliver energy. This energy might be heat energy, cold energy, radio frequency, or microwave energy to destroy the endometrium. We have 7 technologies currently for non-resectoscopic techniques: the bipolar radio frequency, the cryotherapy, circulating hot water, combined thermal and bipolar radio frequency, vapor ablation, microwave ablation, and hot liquid filled balloons. The first device is the bipolar radio frequency, such as the NovaSure. The idea is that it is a 3-dimension bipolar mesh probe that delivers electrical radio frequency current until a specific tissue impedance or resistance is reached. The device is inserted into the uterine cavity, and the mesh is expanded inside the uterus to get in contact with the endometrium. Then suction is applied, drawing the endometrium nearer to the mesh probe, and the system is automated, and it shuts down automatically when complete ablation occurs, or after 2 minutes, by which the depth of ablation is 4 to 5 millimeters. So it only takes 2 minutes for the endometrium to be ablated. One of the major advantages is that it doesn't require endometrial preparation, as it adjusts the ablation depth by measuring the tissue impedance. As I told you, it is automated. May be successful in patients with endometrial polyps or fibroids of a small size, less than 3 centimeters. The outcome after 5 years is very equal to resectoscopic endometrial ablation, with low rates of repeated ablation and low rates of hysterectomy. The second device is the cryoablation, like the hair option device. This device uses a cryoprobe, which is inserted into the uterine cavity under ultrasound guidance. Then it is cooled by liquid nitrogen to minus 90 degrees centigrade, which will form an ice ball of around 5 centimeters in diameter. The tissue adjacent will reach minus 20 degrees centigrade to a depth of 3 to 5 millimeters, destroying the endometrium. The cryo technique is less painful, either in the operative or post-operative period, than the other high-temperature devices, and may not need cervical dilatation because it is only 5.5 millimeter probe, so it can be an outpatient procedure and may be used without general anesthesia or without anesthesia. And the ultrasound visualization help to ensure complete ablation and avoid complications. The outcome of cryoablation versus roller bore ablation, again, similar rates of reduced uterine bleeding, amenorrhea, the need for repeated ablation, and hysterectomy. The third device is the hydrothermal ablation. This hydrothermal ablation is used by hysteroscope. A hysteroscopic sheath is inserted inside the uterine cavity. Then under hysteroscopic visualization, saline at the temperature of 90 degrees centigrade is administered into the uterine cavity and left there for 10 minutes, destroying the endometrium and doing the ablation. A cool down phase is very important, is then done for 1 minute with the fluid at 45 degrees centigrade. The main advantage of the hydrothermal ablation, it can be performed in patients with intracavitary lesion or irregular shape of the uterus, because it is fluid that fills the whole uterine cavity irrespective of its shape, so it can do the ablation in irregular shaped uterus. The major disadvantages is burn. Vaginal burns has been reported, perineal burns, leg burns, and thigh burns from contact with hot water if there was a poor seal on the cervix or the sheath was removed before the intrauterine fluid are cooled, and this is very important point for the hydrothermal ablation. Also, the outcome is comparable. After 3 years of follow-up, there was reduced bleeding, and the rate of hysterectomy and repeated ablation were equal between the hydrothermal ablation and the roller ball ablations. The fourth device is the combined thermal and radiofrequency ablation, the Minerva. This system uses a silicone membrane which is applied to the endometrium inside the uterus. Then endometrial heating is achieved by circulating argon gas. This gas is heated by the radiofrequency current. So both radiofrequency current and heat undergo ablation of the endometrium. The main advantage of this device is the high amenorrhea rate. It has the highest amenorrhea rate among all devices. However, the disadvantage, lack of data regarding long-term outcomes. We are having only 1 year of follow-up after ablation by the combined thermal and radiofrequency ablator. The vapor ablation is the fifth device, which is Samara system. Here we use vapor, which is delivered inside the uterus for 2 minutes or 120 seconds maximally to ablate the endometrium after sealing the uterine cavity with 3 inflatable balloons. The vapor generator will regulate the vapor pressure and temperature via sensors on the probe. It can be performed without cervical dilatation because, once again, the probe is only 5.2 millimeter, so it can be an outpatient procedure, and the outcome after 1 year, very high satisfaction rate, very high amenorrhea and reduced blood loss rate, and also less need for reablation and hysterectomy. The sixth device is the microwave ablation. This device uses a microwave probe, which is inserted inside the uterine cavity to raise the tissue temperature to 75 to 85 at a depth of 6 millimeter. Here the depth is 6 millimeter. It is more depth than the previous devices. The probe is moved from the cornea to cornea, then down to the central area of the uterus, moved from the left to right, then down above the isthmus till the whole uterine endometrium has reached the desired temperature, and this temperature can be seen real time on a computer display so that we are quite sure that the endometrium has reached the required temperature for the ablation. The total treatment time ranges between 3 and 5 minutes. This microwave ablation allows treatment of patients with submucous leiomyoma around 3 centimeters or less because it has direct contact with the tissue immediately, and the uterine cavity size maximum is larger than with other resectoscopic ablation, non-resectoscopic ablation devices. We can here use it in endometria or in uterine cavities up to 14 centimeters. It is FDA approved for 12 centimeters, but studies show that up to 14 centimeters it can do the job. However, there is major disadvantage, which is the preoperative measurement of myometrial thickness, and the post-operative hysteroscopy are required because there were case reports of bowel burns without perforation. The heat is very high so that it can affect the whole myometrium, even affecting the nearby bowel loops. So the minimum myometrial thickness should be 10 millimeter, not less than that, with temperature no more than 90 degrees centigrade, and we use it maximally up to 85, and the time should be less than 8 minutes, and preferably from 3 to 5 minutes to prevent bowel injury. The outcome compared to endometrial resection, here we have 10 years follow-up that shows similar rates of amenorrhea, similar rates of repeated ablation, and significantly less hysterectomy rates. The last device is the hot liquid balloon thermoablation. We have 3 types of balloons: the ThermaChoice, which is FDA approved, the Cavatherm and Thermablade, which are used in Europe. Here, a silicone balloon on a probe is inserted inside the uterus, then expanded with a solution to a pressure of 160 to 220 millimeter mercury, very high pressure indeed that causes extreme pain to the patient even post-operatively. Fluid is heated to 68 to 87 degrees centigrade for 8 to 10 minutes. There are more perioperative pains than other techniques due to the high pressure, and the outcome for older balloons after 4 years, repeat ablation rate was 5 to 11%, and the need for hysterectomy ranged from 2 to 13%. With newer versions, however, after 1 year, there seemed to be less rate of reablation and hysterectomy, but we lack long-term follow-up data to give a final decision about the liquid balloon. Now, comparing the non-resectoscopic techniques and the choice between them. The 7 devices reduce uterine bleeding in more than 80% of patients treated with low complication rates. Thus, in the absence of difference, choice is based upon the following: the uterine characteristics, the size and intracavitary lesions, because some devices are used at different sizes, others are not, and in the presence of intracavitary lesions and in their absence, the ease of use in the office setting and or under local anesthesia, the ease of preoperative preparation, and the surgeon familiarity and the preferences, of course, and the device availability in our area. Points to consider in non-resectoscopic ablation are the presence of leiomyoma. Microwave ablation and the cryoablation are FDA approved in patients with small submucous or intramural fibroids of less than 3 centimeters in size. Endometrial polyps, they can be removed prior to the ablation, but the microwave and bipolar radiofrequency and the ThermaChoice devices are FDA approved for polyps less than 2 centimeters in diameter. Endometrial preparation with 30 to 60 days of pre-treatment with gonadotropin-releasing hormone agonists, such as the leuprolide 3.7 milligram per month, is advised for non-resectoscopic ablation, but these devices do not need the endometrial preparation. The bipolar radiofrequency, the NovaSure, because it is automated and adjusts itself to the different tissue depths. The combined thermal and bipolar radiofrequency device, the Minerva, the Mara vapor devices that are used early in the proliferative phase, in which the endometrium is already thin. So every apparatus or every device has pros and cons. The bipolar radiofrequency doesn't need endometrial preparation. Treatment time is 1 to 2 minutes, and we have long-term data available. For cryoablation, the device diameter is 5.5, doesn't need dilatation, and ultrasound guidance allow visual guidance, and long-term data are available. For circulating hot water, may treat different cavity shapes, direct visualization, long-term data are available. For combined thermal and radiofrequency, it doesn't need endometrial preparation, and for vapor system, it doesn't need endometrial preparation. The device is very small, 5.8 millimeter in diameter. Treatment time is 2 minutes, and the maximum sounded length can reach up to 14 centimeters to apply this device. Finally, before I go, what about ablation versus the levonorgestrel releasing intrauterine system? This is actually very important. Both have similar reductions in the menstrual blood loss and similar improvement in the quality of life. The levonorgestrel intrauterine system is more cost-effective and associated with less complication than endometrial ablation. However, patients who are treated with levonorgestrel intrauterine system require more than twice many surgical interventions compared with endometrial ablation, as reablation and hysterectomy. Counseling and individualization is important, so in my humble opinion, the intrauterine system comes as a first choice in treatment of benign menorrhagia before resorting to any type of ablation, whether non-resectoscopic or resectoscopic, except if there is a frank contraindication to the use of the intrauterine levonorgestrel releasing system. In conclusion, Mr. Chairman, all of the non-resectoscopic devices appear to have similar efficacy and complication rates. Each method has advantages and disadvantages regarding the operative duration, the perioperative pain, the complications, etc. Studies found comparable treatment efficacy for bipolar radiofrequency, microwave, and hot liquid filled balloon ablation devices. However, the levonorgestrel intrauterine system is more cost-effective, associated with less complications than endometrial ablation, and can be a good first choice for the majority of patients. And thank you very much.
We will postpone questions to the end of the session because we are running out of time. Okay, one question.
I'm going to ask a provocative question. We see so many patients who've had an ablation and a tubal ligation years ago, and now they're remarried and they want to have a baby, and we've been told we don't dare try to do IVF, even if they've got normal menstrual cycles, because of the danger of placenta accreta and procreta. So I'm wondering, is there any indication where it would be safe to transfer an embryo and get pregnant a woman who's had a prior ablation? And also, why do we need to do ablations if you have other methods, like a Mirena IUD or progesterone?
That's the issue. I said finally that intrauterine system, the Mirena, gives the same rate of success, so it is a very good first choice. But there are many people advertising for these non-resectoscopic devices, and it is the most used in the United States of America and Europe rather than other techniques. And for the pregnancy, I didn't mention the contraindications. As you know, future fertility is a contraindication. The need for future fertility is a contraindication for endometrial ablation by any form. Okay? Shukran.
Hydrothermal ablation. Is there any precautions to prevent escape of the hot fluid from the tubes to the intraperitoneal cavity with subsequent harms? Yeah.
Well, there is an adjusted volume is inserted inside the uterine cavity according to the uterine cavity length and width, which maintain the pressure inside the fluid inside the uterus without escaping to the tube. Exactly like when you are doing hysterosalpingogram. You can inject under vision, and here hydrothermal ablation you are seeing by the hysteroscope. You can inject under vision a minimum amount which does not flow to the tubes. So here, the amount of water injected will not go through the tube outside the uterine cavity and to the tube. Okay? Shukran jazeelan.
Next speaker, Professor Paul Lorax from South Africa. Professor Paul, he is a Chief Executive Officer of the very beautiful country in Cape Town Fertility Center, one of the largest private fertility clinics in the country. He served as a president of South Africa Reproductive Medicine Society for 2 terms, and is currently the Secretary General of the African Federation of Fertility Society. Professor Paul will address us about what should I do with ethmosil. It is very, very important problem now because the cases is increasing.
Thank you very much to my co-chair for the warm introduction, and it's really a great pleasure to be here. I've come all the way from Cape to Cairo, and it's really great to be here with Professor Sarur and the rest of the organizing committee. So I'm going to talk about approaching the niche
the treatment of the isthmoceal and approaching the niche pregnancy. So what is the isthmoceal or the niche cesarean scar defect, diverticulum, pouch? It's got quite a lot of different names. It was actually first described in 1961, and it's a relatively new concept, I think, in medicine. So what it is it's a hypoechoic area within the myometrium of the lower uterine segment. And it's basically a discontinuation of the myometrium at the site of a previous cesarean section scar. And you can see this was described in 2015, which is recent. So it depends how you diagnose it. If you look with ultrasound, you can see it in 24 to 60%, quite a large range depending on which study you read. And if you use saline sonography, you'll see it sometimes even more. But a normal ultrasound will pick it up the majority of the time. It can present in all different ways. In 70%, it's asymptomatic. It's very important to say. And in 30%, there's various symptoms like abnormal uterine bleeding, pain, infertility, and pregnancy complications. There's a whole lot of theories about the cause, but actually nobody knows specifically what causes this. So normally we just say, that obstetrician doesn't know how to close the uterus, but that's not actually any evidence for that. So people have looked at single versus double layer closure, the type of suture, the tension of the wound, whether retrovertebrous uterus sometimes seems to have more of these, maybe there's more tension there. If you have a CSAT, further dilation, and some kind of genetic predisposition are all the theories. So why are there so many of these isthmoceals suddenly? I mean, I didn't even know what an isthmoceal was a few years ago. I thought maybe I missed it, that class in medical school. Maybe I bunked that day. But it's not because of that. It's because it's become more increasingly commonly diagnosed recently. And the reason is because the cesarean section rate has increased dramatically in recent years. The WHO says a Caesar rate should be 15%. We can all debate that, actually, what it should be. But certainly if you look in different countries, for example, the figures I've given you, you can see in many countries it's more than 30%. It is associated, Caesar's rates associated with higher economic living conditions, so it does vary in different countries. So some of the interesting things about it is how big should it be on ultrasound? You know, the original definition was 1 millimeter, but in the literature there's all kind of different definitions. And some people look at the overlying myometrium. What thickness should that be? And should it be more than 50% of the total myometrium from the cavity to the external part of the myometrium? So what is the implications? Does it matter if it's a big defect or a small one? Well, there is a greater risk of bladder injury during hysteroscopic surgery, and it may be better to repair some of the very large ones laparoscopically. There's also a question about, does a large defect predict future uterine rupture risk? And there isn't actually enough data on this. Therefore, there's no indication to just repair it because of this possibility. So the next question is, are these things relevant for infertile patients? And basically, again, there's conflicting evidence. There's one study in 2020, they looked at 150 patients who did IVF transfers with the isthmoceal. It had no effect on the pregnancy rate, except that the embryo catheter got stuck sometimes when you were doing the embryo transfer. But how could it affect fertility? Well, obviously that blood within the cavity could interfere with sperm swimming through the cervix. Some people think that if you do an IUI, it's better from that point of view. The cervix functionality can be affected by it, and the embryo may not implant if there's old blood lying in the cavity, some kind of chronic reaction probably from that blood. So the question is, does size matter? I mean, do we have to worry about the size when we're making a decision to fix it? And secondly, should we only fix them if there's fluid in the cavity, or if the patient's getting a persistent brown discharge, to give us an indication of how bad it actually is? So for abnormal uterine bleeding, if there's not a fertility problem, then you can obviously use medical therapy, and it works very effectively. So you can use a contraceptive pill, will reduce the blood flow, and you can use a Mirena. Mirena is not as effective as many of the other mechanisms. Some people use the Vazan tablet as well, dydrogesterone. You can do surgical treatment, which I'll talk about in a second, a hysteroscopic isthmoplasty, which is really the gold standard. You can do a laparoscopic repair, and there are people who have done laparotomies and excision and vaginal repair, and obviously hysterectomy will cure the problem. So there's a couple of small studies looking at the treatment, is it effective? So Verwoerd looked at 103 patients with abnormal bleeding who were randomized to expectant or hysteroscopic treatment, and there was a significant reduction in bleeding and pain. This can be relevant. Some of the patients have quality of life that's very poorly affected by this. Gubini showed 41 patients who had infertility at hysteroscopic resection, and all of them conceived. So that was quite an impressive study. But, we always have to be skeptical if someone gets 100% success rate. Maybe they're very lucky or something else going on there. And then Fabris had 11 patients with infertility at a hysteroscopic repair and 82% conceived. These are very small studies, and there isn't really that much in the literature to give us a really convincing idea that this technique is an excellent treatment to use. So with the hysteroscopic repair, the concept is basically that you've got a little pouch and you want to narrow the sides of the pouch so that the blood doesn't get stuck there and basically runs out. And there's a diagram there to show you how you just remove the walls on either side of the isthmus seal. So basically, here's a very large isthmus seal. I'm just coming backwards from the uterus. It's quite low down the isthmus seal. That's why people are not sure whether it's actually in the isthmus or in the cervix. And people write different definitions of where the thing is. But here you can see I'm coming down from the uterus, and then there's this large defect that becomes visible as you come down. And there you can see the wall of it here. So this was quite a large isthmus seal in the patient. And the concept is basically, as you can see here, basically that you trim both walls of the isthmus seal to make it a flat line between the cavity and the external part, and this actually works very well. Okay, I'm not going to go through the whole video just in terms of time. The other technique is laparoscopic repair, and the difficulty here sometimes is you don't know where the actual defect is. Sometimes it's a bit tricky, and you don't want to start cutting in the wrong place, otherwise you make a big mess of the lower part of the uterus. So it's important to see where you are. So you can put a hysteroscope in and shine a light there. It's quite useful. Then it's called the Halloween sign. You can use a little Hagar dilator and hook up the tissue a bit so you can see where to cut. And some people use ultrasound as well. It's also important, just in terms of repairing it, maybe to put a Hagar dilator through the cervical canal so you don't completely stitch the cervical canal closed by accident. You should check the bladder carefully afterwards as well to make sure that there's no holes, because sometimes the most difficult part of the surgery is actually reflecting the bladder, because it's often very nicely stuck on the isthmus seal. And then you should try and suture in at least 2 layers to make sure that you get a good closure. We used quite a lot of V-lock and other suture, but I had an interesting case, a horrible complication once, of a patient who got a fistula between the bladder and the isthmus seal. She got a vesicouterine defect with V-lock, and when we opened up, the V-lock bulb seemed to be poking through the bladder. So I'm not sure if other people have had complications with V-lock or not. So here's just a quick picture showing you that the bladder must be reflected, and then you find your isthmus seal, open it, and then basically we just do laparoscopic suturing. So, and then just to end quickly, a topic that gives people gray hairs. There's nothing worse than hearing that there's now a pregnancy that's landed in the isthmus seal. And this occurs in about 1 in 500 pregnancies, or 4% of ectopics. And the first case report was actually 1978 in South Africa, and they found it afterwards when they'd opened the patient's abdomen. And then the first detection of a transvaginal pregnancy was in 1990. So it can present with bleeding in pregnancy, pain. The patient may collapse if it ruptures, and it can be confused, though, with miscarriage, with products coming through the cervix. Could be confused with a cervical ectopic and a regular ectopic pregnancy. So there's certain diagnostic criteria that you must use when making the diagnosis of a pregnancy in the isthmus seal. For example, the cavity must be empty. You must see the pregnancy sac in the isthmus seal. You must see the cervical canal normally underneath it, so it isn't a cervical topic, and you can see increased vascularity around it. So the options for treatment of these things is medical treatments. There are various types of medical treatments, and surgery. And you have to be careful if you're going to do an evacuation of the uterus because you can get bleeding from there and there's no uterus to contract around it to stop the bleeding. So some people have used a Foley's catheter afterwards to try and tamponade the bleeding. And you can also do it, which is a good suggestion, if you use methotrexate first to try and shrink the thing and stop the vascularity there, often the procedure is easier. Some people have used hysteroscopic resection as well, also using pre-treatment with methotrexate. You can use laparoscopic excision and suturing, but you must be prepared that it could be a difficult operation. So a few pictures of isthmoceal pregnancies. I won't talk about that today. So just to mention, for treatment of the pregnancy, you can use medical treatment combined with surgery. It's important to think about that. We had one case where a normal gynecologist in our hospital did an evacuation, and then the patient collapsed afterwards in the ward and had to have an emergency laparotomy, and there was massive bleeding from the isthmoceal. And then she came to see me afterwards, and I could see the large isthmoceal defect, and they were worried about a future rupture of the uterus. But when I scanned her a few months later, actually it closed up spontaneously, and we didn't have to do anything. Yeah. And just to show you some interesting stuff, here's a pregnancy, one in the isthmoceal and one in the uterus, and another one with twins in the isthmoceal. So we get some really strange things. So thank you very much, and I wish you all the rest of the conference.
Thank you. Thank you, Paul, for this excellent presentation. I would ask you about the recurrent of after repair. Recurrent.
Oh, the recurrence.
Yes.
Yes, there is a recurrence risk. Sometimes the repairs, you think you've done a brilliant job, and you go back and scan the patient afterwards, and there can still be a defect. It may be smaller, and the patient's symptoms might be better, and sometimes you still get some benefit, actually. And certainly, but yeah, one has to, this is not 100% cure rate with either hysteroscopy or laparoscopy, and one has to counsel the patient about that. It's not a simple operation that always works. Thank you.
Do you have a question?
سؤال مهم. يعني cesarean scar defect is evolving problem, increased as regarding increasing the rate of cesarean section all over the world. What is the etiology? Related to the surgeon or related to the patient? Second question. During repair, hysteroscopic repair of isthmoceal, we scratching around the site of defect, and more area more patient by this scratching, and this more increasing the more weakening point in the uterus, and increasing the rate of placental accretion.
Firstly, just to say, we don't know exactly what causes the isthmoceal. It's obviously related to cesarean section, but I don't think it's related to technique or anything like that. I think it's basically just that we're doing more cesarean section, so we're seeing it more often, that's all. You know, I don't think anybody's isolated what particular technique could stop it. It seems counterintuitive to cut tissue around it. So I understand what you're saying. You feel like you're making a bigger hole around it when you're fixing it. But it does work. When you narrow away that thing, many of the patients do in fact get pregnant afterwards. But you should be careful, and that's why you should measure the myometrium carefully, and there's less than about 3 to 4 millimeters of myometrium overlying it. It could be dangerous to cut there, and I think perhaps laparoscopy is better in that situation.
Okay, thank you. Next speaker again, Professor Mohammed Mabrouk. Okay,
مرة دي بدري والله.
He will address about the robotic assisted surgery for endometriosis. Does it make difference?
Thank you very much. Sorry, I know at the end of the session, speaking about robotic surgery may be not very interesting, so I will try to be as less boring as possible. So to start with, who believes that robotic surgery for deep endometriosis might have an impact? Regardless the price and the cost and all these things. Okay, so in the morning you heard it very clear from Professor Kennedy, there is no role at all. I'll do my best. Anyway, So I'll speak about the role of robotics in deep endometriosis, not in superficial ovarian endometriosis, and these are my disclosures. And I will not answer this question because we have already answered it, but I will focus on this question. Is deep endometriosis surgery a complex surgery? Great. Does it have potential complications? Great. So we agree that it is a complex surgery and it has potential complications. And there is a big controversy about the definition of complications in deep endometriosis surgery at all. A publication by Professor Jack Donay in Human Reproduction 2010 had 7 letters to the editors because they need to standardize the definition of complications for endometriosis. And let me give you an example. You do a myomectomy. There is a classification that manages or that defines the complication that you have after myomectomy. The Clavin-Dindo classification is 1, 2, 3, 4. Fine. I do an endometriosis surgery. I remove a rectovaginal nodule. The patient cannot wee for the rest of her life. She needs self-catheterization. Where does it fall here? It doesn't. It doesn't. Like if I am a urologist, and please take this example and don't hate me, and I do a prostatic removal, prostatectomy, and the patient after my prostatectomy has impotence, where does this fall here? Why do we agree that a male should have a robotic prostatectomy, but a female cannot have nerve-sparing surgery by robots? Why? Also because the impact of this after the male surgery is immediate. But I have shown you that it takes a lot of years. So for us, deep endometriosis surgery is not a problem. Robotic is not useful. And this is why, again, the literature is very unfair. And look here, I will not go too much in depth of this, but you agree that deep endometriosis affects the nerves. Who agrees about this? Great. So we all agree that deep endometriosis, and it's enough to look at this picture, and this is a real slide. This is endometriosis, and this is the nerve. Look at this picture, and you will imagine the relationship between, there is neurotropism, neurotrophism, neuroangiogenesis in the deep endometriosis nodule, and we know for sure that it affects the nerves. Do we have only somatic nerves in the pelvis, or we have also autonomic nerves? We have autonomic nerves, sympathetic and parasympathetic, that control the functions. Fine. Is sexual satisfaction in a female is as important as erection in a male? Yes. So why we are still saying, no, it's not important? And I will show you the literature where they based their hypothetical lack of value of robotic surgery. And again, these are the nerves. I will not take much of your time. We were the first in the world to explore this in the patient, in rectal functions in deep endometriosis patients. So I am a deep endometriosis patient. Do I have rectal and urinary dysfunction without surgery, yes or not? The answer is yes. And we published this manometric study in 2012 on fertility and sterility. It's not only rectal, it's also urinary, and the same group we published on sexual functions as well. So yes, before surgery, we have a problem because it's a neurotropic disease. So after surgery, is this affected? Yes. And it depends obviously on the extent of the disease, parametrial, yes or not, segmental bowel resection, yes or not. We are doing nerve-sparing surgery, yes or not. So urinary dysfunctions after surgery have been published and documented in the literature, and I know for the interest of time, I will not go in depth of this. However, nerve-sparing surgery for deep endometriosis. Who believes that this is something feasible? Good. We believe it's feasible, but you have just said that endometriosis affects the nerves. Yes, it's feasible, but not always possible. If I have a tool that helps me to see the nerves, operate in 360 degrees, very fine dissection, and take the endometriosis and leave the nerves, I don't believe this is a bad tool or an unnecessary option. Anyway, again, I will not bother you with the cadaveric studies that we did, but here comes the question. Can robotic surgery help? And this is the big problem if you're working in a system where I am working, where you present a business case and say to them, fine, I need a robot. How much is the robot, Mohammed? 1.6 million pounds. Only? Oh, this is too much, yes, but this is not the problem. The problem is for the cost per patient. Every patient that has her surgery has a big cost. However, the new systems made this much, much better because they lease the robot for the hospital, and then the more patients you operate, the less is the cost per patient. I will not go in depth of this, and in Cairo now there are 4 robots from the new generations from other companies. So can robotic surgery help? Again, yes. Then this is the answer of the managers. They say to you, okay, Mohammed, but endometriosis is a benign disease. Yes. So name a malignant disease that affects the quality of life and puts the patient in all this pain for 10, 20 years of her life. There is no disease. It's a benign disease, yes, but we know that it affects the quality of life, quality of sexual life of the patients. And I hope videos work. Anyway, so this one, anyway, this is a left lateral, yes, this is a left lateral parametrectomy for a cervical cancer, where we use to operate these patients in laparoscopy before the leg trial. I'm sure you appreciate that this is a very easy surgery. This is a wartime operation, but the retroperitoneum is totally healthy. But look at this. Same left lateral parametrium, but in a deep endometriosis patient. Look how there is a fibrous tissue here around the ureter, and how difficult it is with a straight stick instrument to mobilize and isolate the ureter, and to remove this deep endometriosis while conserving the nerves. Same left lateral parametrectomy done with a robot here. And look to the tips of the instrument, the stability of my hand, how I can see in 3D, and how I can move this way to excise and dissect without. And would this impact the outcome of the patient? Yes. In terms of what? In terms of function. Now, again, this is the urology, and the urology robotic assisted rectal prostatectomy since years, it has been the standard of practice. Fine. Is there an evidence to support what I'm saying? The answer is unfortunately no. But let's check the evidence. This is the La Rose randomized trial. Patients randomized robotics, not robotics. Interestingly, 50% of the patients who were in the robotic arm didn't have endometriosis at all. So they used the robot to do diagnostic laparoscopy, and 50% didn't have. And the parameter was operating time. When the robot used to take, I don't know, ages for ducking and unducking. Operating time is important, I can understand. But this function and the nervous function of the patient is much more important. And this is again another comparative study, 1,000 patients, and they use as a primary outcome measure operating time. Unfair. And then comes another review of literature that states this: money for nothing. Robotic surgery cannot help. But actually look at what they said. They said, fine, you pay money, but there is a limitation for the robotic surgery, but there are also some advantages, and let me explain to you, because for the connection issues, the things are very, very small. I'm sorry, but anyway. So the high degree of movement, they give it as an advantage, but the docking time as a disadvantage. The big size of the trokers. Now with the new generation robots, you have trokers of 5 millimeters. You have separate bedside units that you can attach to any place, not a big unit, a big chunk of instrument that you have to duck on the patient. So, and these are the advantages, and the cost per intervention is getting lower and lower as we started to use the laptops. When we started first to buy laptops or mobile phones, these were extremely expensive. Now, there used to be one company, monopoly, buying and selling, producing Da Vinci robots. but nowadays there are many other companies. So, not to forget that the surgeon is important. And doing a 5 or 6 hour surgery in laparoscopy, compared to robotic-assisted surgery, the surgeon is much more comfortable and has much less complications and problems in the future. So, here comes the question. We don't have strong evidence to support what we are saying. We need comparative studies, and we need to use our minds and use value-based medicine, because there is also common sense. There has to be a common sense of what we are doing. And for the evidence-based medicine issue, I would invite you, please, 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 to read this paper done by my head of department, my chief now, Professor Gordon Smith in University of Cambridge. And he published this paper on the British Medical Journal in 2003. And it is called The Parachute Approach, The Parachute Approach to Evidence-Based Medicine. And he invites, who said that using a parachute, if there is a problem with the aeroplane, would prevent you from having morbidity or mortality? Who said it? Oh, this is where he invites the advocates of only and exclusively, if you have a level 1A evidence, we can bring you the device to jump. Fine. You are randomized and jump from the aeroplane without a parachute and prove that a parachute is important. So, in summary, I don't think it's something new. I believe that robotics are very important and will help in deep endometriosis surgery. And in my personal opinion, this is simply an evolution. And I really don't think that we need a randomized controlled trial to prove that this is better than this. Thank you very much for your attention.
Okay, thank you very much, Professor Muhammad Mabrouk, for this excellent presentation. One question, please.
Yes. Microphone for the doctor, please. Thank you very much.
شكرا دكتور محمد مبروك، ألف شكر على المحاضرتين دول. I think we complicating issues. احنا مديين الأمور أكتر من حقها. We all know that endometriosis is not a disease, it's a spectrum of diseases. We all know it's a benign condition. This is not a question, this is a comment. We all know that it's a benign condition with malignant behavior. We all know the adhesions due to endometriosis are the worst adhesions you ever see. The point is, if you have, we as gynecologists, we all know we have to cut the vicious circle. For example, if we have big endometrioma, we deal with it. If we have something that interferes with pregnancy, we deal with it surgically. If we have endometriosis-associated pain, we deal with it either medically or surgically. Now, if you have deep infiltrating endometriosis affecting the bladder wall or affecting the rectovaginal septum or affecting the rectosigmoid, this is not our business. Breast cancer دي لعبة الدكتور الانكولوجيست الصغير النايب. Breast, because he is an oncologist, I think deep infiltrating endometriosis of the bladder is the job of the urologist, neurosurgery. Rectosigmoid, this is very simple maneuver in the hands of the oncologist or general surgeon. So مش لازم نغرس نفسينا في الحاجات دي ونخليها nerve sparing. If you're doing hysterectomy, for example, you are not selecting nerves to avoid obturator in radical surgery or so. If you're dealing with the McEnroes, you are not dissecting the nerves and so and so. Pre-sacral neurectomy for pelvic pain, midline. If you're dealing with lateral or pelvic wall, you have to consult the vascular surgery because this is very risky to deal with. Thank you, sir.
Thank you so much. Yeah, I think your comments about exactly who tackles which operation is relevant here. But thank you very much for an
Thank you,
excellent
sir.
presentation. It
Thank
was
you, sir.
wonderful. Thank you.
Thank you very much. Thank you.
Thanks.
Thank you very much. Now our last speaker, we will return back to Ismothil, Professor Khattab Abdel Halim Omar from Dumyat University will address us about a novel technique. الأزهر مكتوب كده في تمام. He will address us about a novel technique for repair of cesarean scar niche.
Right here? Perfect.
Thank you. Show, please. Slide show.
Yeah, it just normally doesn't pop up on. Okay, you're very welcome.
Assalamu alaikum. This is proposal for innovative technique of repair of niche. Objective of our talk: diagnosis, current methods of repair, anatomical considerations, histological considerations, and surgical, and final discussion. With rising rate of cesarean section, niche is an emerging clinical problem. Poor healing of the uterine scar results in anterior uterine wall pouch called cesarean niche or isthmocele. Cesarean scar defect can be defined as indentation of the myometrium at the site of cesarean scar for 2 centimeter or more, 2 millimeter or more, or for a depth of more 50% or more of the myometrium, or when the remaining myometrial thickness is less than 2.2 to 2.5 millimeter. Risk factors for niche formation: when performed, cesarean section is performed in advanced labor, more than 5 hours of active labor and more than 5 centimeter cervical dilatation, larger defects result. A direct correlation can be concluded between the number of cesarean sections and the frequency and size of the defect. I mean, defects were seen in 60%, 80%, and 100% of women who had 1, 2, or 3 or more cesarean sections, according to Ozer et al. 2009. How to diagnose? Symptoms first. Gynecological symptoms: post-menstrual spotting reported in about 1/3 of cases. Other forms of abnormal uterine bleeding include erratic and prolonged menstruation and continuous brown discharge. It's hypothesized that lack of coordinated muscular contraction around the scar allows menstrual debris to be collected in the defect. Other symptoms, symptomatology profile include dysmenorrhea, dyspareunia, and the chronic pelvic pain, very similar to endometriosis, caused by chronic inflammation and or lymphocytic infiltration present in the scar. Larger niche are more likely to present with pain. Approximately 10% have lower pregnancy rates, subfertility, compared with women with previous vaginal delivery. When pregnancy is يعني احنا كده قلنا الجينيكولوجيك symptoms، نقول دلوقتي على الobstetric manifestations. When pregnancy is implanted in the scar, blood supply to the sac is more abundant than in normal intrauterine pregnancy, and heavy bleeding which occurs even when pregnancy miscarry early. يعني الابورشن اللي بيحصل لو حصل ابورشن على cesarean scar pregnancy بيبقى فيه heavy bleeding أكتر من الابورشن في الانترايوتراين pregnancy. Myometrial involvement is the principal reason for this heavy bleeding. Almost all cases will present with placenta previa and or placenta accreta with significant near-miss morbidity and mortality, as well as loss of future fertility, because cesarean hysterectomy is the optimal treatment of placenta accreta زي ما كل حضراتكم عارفين. Diagnosed by ultrasound. Niche may be identified as thin hypoechoic line extending from the endometrium, going through the endomyometrial junction, and then through the myometrium of the anterior uterine wall. ده niche. Since physiological fluid is commonly seen intrauterine in the uterine cavity during the mid-follicular phase of the cycle, niche evaluation should be done by transvaginal scanning between day 7 and 14 of the cycle. This is the best time. Gel infusion sonography seems the best ultrasound technique for demonstration of niche. دي حضراتكم طبعا صور كلكم عارفينها للنيش، وعايزين بس نلاحظ الهايبو اوكويك لاين اللي extending from the endometrium through the endometrial myometrial junction then through the myometrium. Topography of the niche. دي المعالم او الخريطه بتاعت النيش. احنا بندور على، طبعا هو ديفكت في الانتيريور تراين وول شور، ولازم يكون عندنا اللاند ماركس دي عشان احنا عايزين 6 ايتمز تو ريبورت اون الترا ساوند. فيرست ويدث اللي هو نمره 1 قدام حضراتكم، then depth العمق بتاعه، 3 residual myometrial thickness اللي هو من الضم لحد السيروزا، adjacent myometrial thickness اللي هو نمره 4 بيبقى في الابر بوردر. finally 2 items ما لهمش علاقه بالنيش، يعني مش دايركت ميجرمنت اوف ذا نيش، اللي هو نيش تو فيزايكوتراين فولد اللي هو نمره 5، ده بيتاخد من الضم بتاع النيش، الضم اوف ذا ديفكت لحد البلادر السوبيريور سيرفيس اوف ذا بلادر، والنيش تو اكسترنال ديستانس من اللور اند اوف ذا نيش تو ذا انترنال تو ذا اكسترنال اوس. اسف. مانجمنت نيش تو فيزايكوتراين فولد ديستانس اند نيش تو اكسترنال اوس ديستانس اللي هم اخر 2 ايتمز اتكلمنا عنهم 5 و6 may be important in planning appropriate surgery of niche. Niche may be multi-pocket. Niche may be multi-pocket. Each branch is treated according to depth and remaining or residual myometrial thickness. Branches and width are best assessed in the transverse plane، مش الساجيتال بلين اللي احنا كنا شايفينه ده، بيبقى احسن في الترانسفيرس بلين. Current method of repair: hysteroscopic resection of the distal ridge with or without niche ablation. Not recommended in cases with residual myometrial thickness أقل من 3 ملم because of the high risk of bladder injury. Also, hysteroscopic resection just changes shape of the niche from a pit to a wedge-like depression, but it doesn't offer repair of the defect. It only improves the bleeding problems وشور مش هتصلح infertility problems. Second method, laparoscopic repair may be associated with good anatomic results, but surgical dissection is usually difficult with risk of bladder injury. الحقيقه laparoscopic repair is performed under hysteroscopic guidance, والhysteroscopic repair performed under laparoscopic guidance. This means high cost. يعني دي من الcons of the methods. The recommendation is hysteroscopic resection of niche اللي هو اكتر من 3 ملم residual myometrial thickness and combine the laparoscopic approach في حالات النيش اللي الريزيدوال myometrial thickness بتاعتهم اقل من 3 ملم. باقي عندنا الترانسفاجينال ابروتش سيمي ايديال اوبريشن with better exposure of the defect, safer dissection of the bladder, lower cost and avoidance of abdominal scars. The scar is removed. احنا بنعمل ايه بقى في النيش ريبير؟ The scar is removed and its fibrous edge are trimmed to ensure good healing of the uterine wound. This might necessitate removal. ده بقى التحفظ بتاعنا على الموضوع. This might necessitate removal of significant volume of muscular tissue with possible shortening of the uterine dimensions. ايه البروبوزال بتاعنا؟ rotational grafting of the niche using the round ligament. الراوند ligament anatomically حوالي 12 سم 12 سنتيمتر at least half centimeter thickness، ممكن حتى يبقى 3 اللي يدوس على ده عشان الصوت.
You trying to move slides or no? You trying to move it there?
أنا آسف. The round ligament. Function of the round ligament is at the best controversial. it is claimed that the round ligament keeps the uterus anteverted. However, about 20% of women has retrovert RVF uterus in spite of having well-formed round ligaments. Also, RVF position is not a disease. RVF position is an equivocal health condition. The symptoms attributed to RVF uterus can almost be completely removed under placebo effect. The myometrium. The myometrium contains myocytes and fibrocytes. Proportion of myocytes to fibrocytes varies according to parity of the woman. Both smooth muscle cells and fibrocytes are categorized either as slowly renewing cells or as stable cells. يعني هم مش good renewing cells زي الاندوميتريوم أو زي البريتونيال سيروزا. Slowly renewing cells may actually slowly increase in size. Stable cells are cells that divide episodically and slowly. The two cell populations, fibrocytes and myocytes, of the myometrium have limited mitotic activity. Proliferation of the myocytes. The myometrial cells proliferate during the normal menstrual cycle and during pregnancy under hormonal control. Smooth muscle cells may respond to injury by mitosis. The mechanism of development of uterine scar is still unclear. However, the pathophysiology may be related to the surgical technique and the patient individual factors. The patient factors include the individual health differences and the genetic predisposition. It's interesting to know that smooth muscle cells also possess fibroblastic activity, i.e. synthesize connective tissue instead of muscular tissue, playing a part in the scar formation. And our proposal, why grafting? To restore the uterine dimensions. And to obtain better healing and reduce possibility of recurrent niche. The round ligament seems ideal to serve as a possible excellent graft because, like the uterus, it's composed of smooth muscle. Its own mesentery يبقى أحسن ما نستخدم amniotic membrane، أحسن ما نستخدم omentum. Its own mesentery اسمه mesoteres offers good malleability to the rotational graft. It has good blood supply اللي هو Samson artery from the ovarian artery and a branch from the inferior epigastric artery near the internal inguinal ring. During pregnancy, the round ligaments stretch and get wider and longer. The proposed procedure الأول هنعمل laparotomy, cutting one or both of the round ligaments at their distal inguinal ends, وبعدين removal of the defective uterine scar, trimming of the fibrous edges, وبعدين use one or both round ligaments as rotational graft and interposing them in the uterine wall. Finally, fixation of the graft. زي ما انت حضرتك شايفين كده، احنا السهم المزدوج الراس ده اللي احنا يعني هنقطع الراوند ليجامنت هنا، وبعدين نروح عاملين روتيشن كده وجايبينه في السكار بعد ما نعمل تريننج للفايبرس تيشو بتاع النيش، وبعدين ده بروسيدور may be done laparoscopically. In some cases where cutting of the distal end of the ligament اللي هي ناحيه الانجوينال ليجامنت may be difficult، ممكن نقطع الليجامنت عند الكورنوال اند ونعمل الروتيشنال جرافت بتاعتنا برضو، يعني ماليبل من الناحيه دي وماليبل من الناحيه دي. Indications for the proposed procedure: cases of abnormal uterine bleeding اللي هتبقى على الفيجو كلاسيفيكيشن والبالم كوين هتبقى in particularly those with large length or width, thin اللي معاهم thin residual myometrial thickness، اللي معاهم thin adjacent myometrial thickness which is expected to be fibrous rather than muscular due to previous multiple uterine surgeries or previous unsuccessful repair، اللي معاهم absent or very short niche to external os distance. Repair of such cases means ان احنا هنعمل ايه؟ هنعمل suturing of myometrial tissue of the upper flap ده muscle to fibrous tissue of the lower flap اللي هو derived from the cervix. يبقى انت بتخيط muscle to fibrous tissue which includes cervical mucus glands كمان. واعتقد ان البروبوزال بتاعنا هيبقى كويس قوي مع المالتي بوكيت نيش. during cesarean section ممكن يعني during cesarean section نعمل البروبوزال بتاعنا ده البروبوزال تكنيك بتاعنا. during cesarean section when the lower flap of the uterine incision انت مش لاقي خالص lower flap في الانسيجن بتاعك، حط اليوتراين الراوند ليجامنت is defective and composed almost of cervical tissue. انت مش عايز تخيط cervical tissue في المنطقه. In conclusion, Mr. Chairman, cesarean niche causes significant morbidity in at least 1/3 of women, especially those with residual myometrial thickness less than 50%. Niche surgery is very effective, but failure might be expected with large defects and very low ones with short niche to external os distance, those with thin residual myometrial thickness, thin adjacent myometrial thickness, those with previous multiple uterine surgeries or previous unsuccessful repair, and with multiple pockets اللي هم الانديكيشنز المفترضين عندنا. Round ligament rotational graft seems hopeful to reduce the possibility of failure of repair in such cases, and thank you very much.
Professor Amar, thank you very much for an excellent talk and very interesting proposal as well about the round ligament graft. I'm sorry that we can't take questions. We just need to move into the next session because we started our session a bit late. But if you've got any questions for Professor Amar, please do ask him afterwards. Everybody, thank you so much for your attention, and thanks to my co-chairs very much. Thank you.
بسم الله الرحمن الرحيم. Welcome to the barrel session 2, Hall B, reproductive diagnostic testing. I have the pleasure to co-sharing this session with Professor Ahmed Abdelaziz, Professor of Obstetrics and Gynecology, Alexandria University, Professor Sami Aid, Professor of Obstetrics and Gynecology, Al-Azhar University. Yes.
Bismillah ar-Rahman ar-Rahim. I have the pleasure and honor to present one of the famous gynecologists, Professor Muhammad Bidawi, Professor and Division Head of Reproductive Endocrinology and Infertility, Department of Obstetrics and Gynecology, Faculty of Medicine, the University of British Columbia, Vancouver, Canada. He's going to give us a topic on AMH in reproductive medicine, the does and the doesn't.
Thank you very much, Mr. Chairman. It's a great honor and a pleasure to be with you today, and I'd like to thank the Egyptian Fertility Society for the kind invitation. So I choose the topic of today's lecture because it's very commonly used in our practice, in our today activities, but there is a lot of misinterpretation of the results, and there are lots of messages that are communicating to patients that are not accurate. So I try to share with you what we should be able to do with anti-Mullerian hormone assays and the results, and what we shouldn't, and what kind of conclusions we should counsel our patients about and what are the points that we should refrain from. These are more disclosures. So I'm just going to give a quick physiological background about anti-Mullerian hormone and touch on the clinical applications as well as the practical interpretation of the assay in different clinical contexts and scenarios. So as we all know, it all goes back to the French endocrinologist Alfred Jost, who did a set of 3 elegant experiments. In the first experiment, under A, he castrated female and male fetuses, which led to the regression of the Wolffian duct and the persistence of the Mullerian. And the second set of the experiment, he grafted a testicle in a female fetus, which led to persistence of the Wolffian and regression of the Mullerian. And the third experiment under C, he grafted only the testosterone crystals next to the ovaries of the female fetus. And that led to persistence of the Wolffian and failure of regression of the Mullerian duct. Consequently, he concluded that the testosterone is very essential for the development of the Wolffian, and there's another substance that is responsible for the regression of the Mullerian duct, and he called it Mullerian inhibitory factor. It took so many years and a lot of work to identify that factor, which was initially called MIS, and now it is the anti-Mullerian hormone, which was found later to be a member of a bigger family of molecules called the TGF-beta family, and it functions by attaching itself to 2 receptors. One of them is specific, that's type 2, and the other is non-specific, which could bind to any member of the TGF-beta family. Depends on where you practice. The assays can be measured by nanograms, like what we have here in Egypt, but where I live in Canada, we use the picomole per liter, which I may refer to in my talk. If you would like to convert picomoles to nanograms, you have to divide by 7.14. So in males, it started from birth that AMH is secreted, and it can reach up to 70 nanogram per ml, and around age 10, it starts to level up to 2 to 5 nanograms, which is corresponding to the female levels. While in females, it's rarely detectable at the time of birth, and then it starts to rise around age 10, and it is measurable in the follicular fluid. And the highest level of AMH that you could find are in 6-cord stromal tumors, up to 3200s, and in granulosa cell tumors in up to 20 nanogram per ml. Consequently, it is proposed for the diagnosis of sexual development problems as well as some neoplasms. So what it actually does inside the ovary, what is the function of the anti-Mullerian hormone? Simply, it regulates the steroidogenesis, and it controls the division of the granulosa cells. So it is responsible for 2 key functions within the ovary. The first one is inhibition of steroidogenesis, and the second one is inhibition of the divisions and the proliferation of the granulosa cells, which will indirectly control the meiotic arrest of the oocytes. Here's the normograms of the AMH. The peak is between age 15 and 25. And you can start to see that the decline of the circulating level of AMH is around age 25, but it's slower decline, and the decline continues to be more steep at age 40. And at the same time, it corresponds to the growing follicular pool, as you can see here in the red. There are so many factors that could affect the assay level and the measurement, one of which that I want you to be very familiar with. If you have a patient on combined hormonal contraception, or a patient who is using long-term progesterone for treatment of endometriosis, for instance, and you do AMH, this is very much 50% of the actual value of the AMH. You have to reconsider the assay at a later time. One of the unique features of AMH is its consistency throughout the cycle. You don't need to measure it on day 3 or day 2 or day 4. You can measure it at any time with a decent plateauing effect throughout the menstrual cycle. It doesn't matter if the patient in the early follicular phase, mid luteal, or late luteal. Here's what I just said. If you study patients who are in long-term suppression with combined oral contraceptive pills, within 5 weeks, there was a significant reduction in the second column in this graph in the level of the AMH. By 9 weeks after combined oral contraceptive use, the assay or the level of the AMH that you're measuring is 50% less than the actual value. So what do we do with those patients? So this is the first do not that I want you to take home, that you should not use AMH as predictor of ovarian reserve in women on combined hormonal contraception or using high-dose progesterone. However, this suppressive effect is reversible. It takes around 2 months for that level to come back to normal. So if the patient goes off control pills, she wants to get pregnant, don't do the AMH this month, wait for 2 months. And if this patient is going to be stimulated for IVF, you have to consider waiting for at least 2 months for a washout period for the AMH to recover and for the suppression of the granulosa cell to come out off so you can stimulate them well. However, patients using Mirena ID, which is a common one, they do not have the same effect. So we see patients all the time coming for egg freezing while they have Mirena ID. We stimulate them directly. You don't need to take the Mirena ID out. I just want to touch on 2 common pathologies that affect the level of AMH. The first one is endometriosis, and I talk about that a lot, and Professor Mohammed Mabrouk talked about it, so I'm not going to go into the details, but I just want to share with you these 3 curves. The top one that you see there is the normal people without any pathology. That's the AMH across the ages. You could see the decline. The one next to it is patients with unilateral endometrioma. There is a decline in the AMH level in patients with unilateral endometriomas, but it's not significant from the baseline. The one near the bottom there is the bilateral endometrioma. You could see how big is the gap between the curves. There is a significant decline of AMH in patients with bilateral endometrioma. Consequently, operating on those patients is quite risky for their ovarian reserve, and you have to consider assisted reproduction first if they are not trying to get pregnant right away. And you have to counsel them about the risk of premature ovarian failure of close to 3%. The second condition where AMH goes into the opposite direction is polycystic ovarian syndrome. We'll hear some talks about that later. And it makes sense because it's coming from the growing antral follicles, and you can see patients with polycystic ovarian syndrome have a lot of growing antral follicles. And what happens actually in the dynamics of the ovary for patients with polycystic ovarian syndrome, that the inhibition of the aromatase will lead to increase of the circulating androgens. So the androgen-estrogen ratio is disturbed, and that contributes to the insensitivity to FSH and the anovulation and maybe failure of treatment on those patients. The big question that we have, and I don't think it's fully resolved, can we use AMH to diagnose polycystic ovarian syndrome? It was looked at a meta-analysis and was found that a level of 4.7 nanogram can be 82% sensitive and 79% specific in diagnosing PCOM, not PCOS, polycystic ovarian morphology. So it can substitute the ultrasound piece of the diagnosis, but it shouldn't be used as a unique diagnostic criteria because we still have problems with the assay itself. So when it comes to AMH and PCOS, the do's are you should use AMH to support PCOS diagnosis, but not to be a diagnostic element. And you should consider AMH level if you are stimulating these patients for ovulation induction, either for simply trying to get pregnant with intercourse or IOI, or they're going to IVF. On the other side, you should not use AMH in the diagnosis of PCOS in adolescents, because in adolescents it's elevated at baseline, so any results will be misleading. And you shouldn't use AMH in polycystic ovarian syndrome as an indicator of metabolic health in those patients, i.e. the metabolic syndrome. So let's move quickly to the clinical utility of AMH. How can we use it in our practice? First, can we use it to predict natural fertility in patients? Many studies were done, not only regarding AMH, but also other ovarian reserve marker with some mixed results, but so far what we can tell that all ovarian reserve tests fail to show correlation with time to pregnancy or predict natural pregnancy. Consequently, a very low AMH does not mean that this patient has reduced fecundability. Conversely, a very high AMH does not reassure the patient that she will indeed get pregnant. So you shouldn't use AMH to protect natural fertility. That's a simple message here. How about age at menopause, which is the other extreme or the other end? Is it really important to know or try to predict the age of menopause? Yes, it is, because if you have early menopause, less than the age of 45, your patients will be at high risk for cardiovascular disease and osteoporosis. And the opposite, if you have a late menopause at the age of 54, then you are at risk of breast cancer and at risk of endometrial cancer. These are the normograms for the relationship between age-specific AMH concentrations and the distribution of age at menopause. You don't need to look into this diagram, but I just try to make it simple for you. If the assay is telling you that the AMH of this patient is less than 0.1 nanogram per ml, that predicts with an 80% probability that this woman will be menopausal in 12 months. But if she's younger, it's not as predictable, or it's not as predictive. So it's 50% probability of menopause in 1 year if they are less than 48. On the other side, AMH does have a very high negative predictive value when it's elevated. So if the AMH is more than 0.1, then you can tell this patient that, I can tell you that you will be menstruating for a minimum of 1 year. So this patient would not be menopausal for a minimum of 1 year after AMH. So 0.1 less and more is good in that direction. So you can use a very low AMH level to protect time to the final menstrual period in older women, but you should not use AMH to forecast imminent menopause in women under the age of 45. How about the AMH as an ovarian reserve marker? That's probably the indication that we use AMH for the most. So we all know that the ovarian reserve tests are emerging or emerged because of the need in assisted reproduction for a variety of reasons. To have an ideal marker, it should be, as we all know, for any diagnostic test, affordable, reproducible, convenient, non-invasive, early detection, high sensitivity, and high specificity, nothing different from other assays here. Historically speaking, we have a lot of ovarian reserve markers, whether they are anatomic, like the AFC, or indirect endocrine markers like FSH and LH, or direct products of the ovary itself like estradiol and AMH and inhibin A and inhibin B, and the historic dynamic test, the clomiphene challenge and GnRH agonist challenge test. Put a red cross mark in all of them. The only three that are really of practical use currently are the AFC, FSH, and AMH. So is AMH is a measure of ovarian reserve? It's precisely not. It's a measure of the functional ovarian reserve. What is a functional ovarian reserve? It is a growing follicular cohort. Any other follicles that are not growing, like the primordial follicles, the AMH does not assay for that. It's not a metric of that. So this is distinct from primordial follicle density. Primordial follicle density is something different physiologically from functional ovarian reserve. So AMH, again, is not a measure of follicular density. It is a measure of functional ovarian reserve. So the big question here, is AMH the best ovarian reserve test? Well, definitely it's better than FSH because it's cycle independent, less intracycle variability, earlier predictor of diminished ovarian reserve and can predict hyperresponse. And it is better than AFC, antral follicle count, because it has less intra and intracycle variability. It's cycle independent, and it's a representative of both the pre-antrals and the antrals, while the AFC is representative only of the antral, as the name implies, etc. So it's not limited to technology. You have to be a good sonographer to do a good AFC. But it has limitations, and those limitations includes the cost, lack of standards, and poor sensitivity for clinical pregnancy, the more variation that we can see in some of those patients. So definitely it's not a perfect test. Lastly, AMH and ART. When we stimulate patients in assisted reproductive technologies, we are trying to run the balance between cycle cancellation and poor response, and over response and ovarian hyperstimulation syndrome. And that is where AMH fits. This is one of the tables that we use all the time to calculate the dose for ovarian stimulation in patients undergoing IVF with a medication. I'm not sure if it's available in Egypt or not, Rocaval. So based on the patient body mass index as well as AMH, you can decide about what your starting dose for stimulating this patient would be. But more importantly, I want to spend a little bit of time to share with you how we use AMH to counsel patients about egg freezing, which is a rising topic here in Egypt. So when I have a patient who's coming for me for egg freezing, for endometriosis or for something else, the first thing I look at her AMH, and I pull that table, and I tell her, let's take a hypothetical patient, a patient who is 32 years old. According to the different assays available in Canada, her median AMH should be between 18 and 20, which is around 2.5 to 3.5 nanogram per ml. What if this patient AMH is 10, not 20 as predicted? If you look into this table, 10 corresponds to age 38. So she's 32, but her AMH assay is the age of 38, or corresponds to age 38. Well, the patient is not interested in that. The patient wants to know how many oocytes or eggs she will be able to get from one AF cycle. That's based on some mathematical modeling. We said she's 32, and she has an AMH of 10. So that is AMH of 10. And you look across from less than age 35. So if you do the best with stimulating this patient, you will get around 10 eggs. Again, the patient's not interested to have 10 eggs or 20 eggs. She's interested in a child. So what does this 10 egg give her in terms of probability of one child? So if she has 10 eggs, when you thaw them, you lose 2 for freeze-thaw trauma, and you will end up with 8. And that gives the patient around 49% probability, according to this calculator, of having one child from that collection. What if she's not satisfied with that number? She wants to improve her chances of having a childbirth to more than 50%. Then she has to do more IVF cycles. So you should counsel this patient from the beginning. You should go for 2 IVF cycles for egg freezing back to back. So she will end up with 20. Then her likelihood of having a child will be around 76%, which is very decent. This is just an arbitrary example to tell you how to implement the use of AMH in your practice when it comes to egg freezing. Should we use AMH to exclude patients from ART? As I said earlier, it is a quantity metric. It predicts egg quantity, the number of eggs that you will be able to retrieve from a cycle. It does not predict egg quality. It does not predict the chance of pregnancy. And there is no AMH level below which no pregnancy occurred. So consequently, the answer to this question is a big no. You shouldn't use AMH to exclude patients from AMH. Again, the do's and the do-nots. So consider AMH and gonadotropin dosing in IVF, and you should not use AMH to exclude patients from ART. How do I counsel? This is my pre-last slide. How do I counsel my patients about the value of AMH? First, you tell her it's not a test of natural fertility. Patients with undetectable AMH can get pregnant if they are still ovulating. And it can help you to triage patients the most efficient way. If the AMH level is good, then this patient has more time, so you can use conservative methods of treatment like ovulation induction with timed intercourse or intrauterine insemination. But if the AMH is very low, you have to be more aggressive and then probably move the patient sooner to assisted reproductive technology. So in conclusion, I hope I convinced you that AMH is an excellent, although not perfect, measure of the quantity of women's growing follicle pool, not the overall ovarian reserve. AMH can be helpful in some contexts for the prediction of menopausal transition, and it may be helpful to support the diagnosis of PCOS, but not as a diagnostic criteria for polycystic ovarian syndrome. And lastly, it's a helpful measure in driving gonadotropin dosing and predicting the number of eggs to be retrieved in IVF cycles. And with that, I thank you very much for your attention.
Thank you, Dr. Deo, for this excellent and comprehensive presentation about AMH. We have been told that you can measure AMH at any time in the cycle.
I would say very much. I guess based on the data that we have, it's okay to measure it.
How to explain its variation after using oral contraceptives?
Well, very much simply because high-dose birth control pills, progesterone, do suppress the granulosa cell of the growing follicles as a part of the ovulation suppression mechanism. And that's where the AMH is coming from. So that is where it is going to be reflecting on the circulating level of AMH.
Is there is any question?
Any question?
Yes, Dr. Mohammed. تفضل. Mike, please.
You can use this one. I can share with you.
Considering the do's and the do-nots in endometriosis patients, especially ovarian endometriosis, do you routinely measure AMH, yes or no? And if you have a low AMH, is this the patient that you counsel, regardless what she will do, for egg freezing because no one knows? Thank you.
Great question. So for the first question about, I think, measuring AMH in patients with AMH, should I do routinely? Or I probably going to use the same answer like what you answered in your lecture about endometriosis surgery. I wish I can, if I have the tool. It's not covered by MSP in Canada, so the patients has to pay out of pocket. But I talked to them about it, and I told them this is a valuable tool to help me make decisions about your care. If you can pay for the assay, I will order it for you. And the majority of the patients will go ahead. So how can I use the results clinically after I do that, particularly in patients with endometriosis? I bring it to them for discussion. I say, listen, your AMH is on the low end. Next question would be, are you starting to plan to start a family very soon? If they are, I say, you will probably should go ahead and start trying right now or shortly, because your AMH will definitely continue to decline. It would never get better than this. Whether they're gonna go for egg freezing or not, that depends on them. If they're ready to start a family, they can go ahead and try to get pregnant. If they are younger, even with low AMH, their chances of getting pregnant is very high. And if they are not planning to get pregnant right away, then the egg freezing comes into discussion with all the financial components that surrounds it. So it's a shared decision making at the end of the day.
Dr. Mohammed, thanks for this comprehensive. Now I want to ask you, what is the significance of the very high level of AMH regarding the response to stimulation and what you are doing in this condition? And I have comment about the use of AMH for prediction of menopause. According to the ASRAM,
can I answer the question first? I'm jet lagged. I will forget your
yes.
your question when you say with the comment.
أكمل أنا كلامي اللي هو there is insufficient data to recommend AMH for prediction of menopause.
Two great questions. Thank you, Professor Abu Bakr. So the first question, I told you I will forget the first question. What was it?
The high level of AMH.
High level of AMH. If they are going for IVF, counsel them about ovarian hyperstimulation syndrome, irrespective of their age, because they can overstimulate. Consequently, I would be very careful in crafting the dose for those patients. I'll use antagonist protocol for those patients right away. And since we do approximately 90% freeze-all cycles, so most likely this patient will end up with freeze-all, consequently would reduce the risk of ovarian hyperstimulation syndrome. I would titrate their dose if I need to. Down the road, we bring them around day 6 for one assay as well as transvaginal ultrasound to count the follicles. And at that time, we may bump or decrease the dose according to their response. As far as menopause, I agree with you, but you have to be careful because that's kind of telling the patient this is the end of your reproductive life. So if they are young, I would be careful. If they are less than the age of 45, I would be very careful to use any assay level to tell them that you'll be menopausal, except when it is very low, less than 0.1. But I can use it the other way to tell them if they are not, if they don't have a family or they want to get a family to jump into it right away because they have a very short window of time. I hope I answered your question.
we will shift to the next speaker, Dora.
And now is the time for second speaker on ultrasound in ERT cycle, which is a virtual presentation done by Professor Dr. Boutros Rez, a medical director, Elite IVF in Houston, and former professor and head of reproductive endocrinology and infertility medical, and scientific director of USA in vitro fertilization. التوبك ultrasound ART cycle. هتبقى recorded ولا next؟ Sorry, Dr. Boutros, inshallah, tomorrow. Now, second speaker is on BCO, morbidity and mortality, done by Dr. Matris Brenstrom. Dr. Mats is present here. هو كان presentation Dr. Mats is MD Sweden Department for Obstetric and Gynecology Academy, University Hospital. He is currently adjunct professor at Baylor College of Medicine.
Thank you for the introduction, and thank you for also giving me the opportunity to speak about something else than uterus transplantation, which actually is my field. But we've also done research in my group on PCOS, not so much about the fertile age PCOS patient, but actually what is happening after menopause and when they get older. And as you know, PCOS is a very common disease in women, and we as gynecologists possibly care for the women all through their life. And as pointed out here in a review from Bart Fauser's group, the focus on PCOS changes in the different stages of life. In adolescence, it's all about the hyperandrogenic side effects, hirsutism, acne, and of course on irregularity or amenorrhea. Then in the fertile period, maybe fertility treatments or pregnancy complications. And then in the peri and postmenopause, it's about possible side effects by the increased rate of obesity, metabolic syndrome, hypertension, and possible cardiovascular risk factors. So I will talk a little about what is happening not only with this morbidity, but also with the reproductive hormones, because that has been focus on our studies. And we have a unique prospective cohort study in Gothenburg, and these patients were diagnosed by PCOS 1956. That was before I was born, 1956 to 1965. And then we have done studies in 1987, 2008, and 2019, when they've had a mean age about 49 years, 70 years, and 81 years. And we have followed them by anthropometry and also reproductive hormones, as well as morbidity. The great asset with this study is that it's a prospective study, but unfortunately it's the size of the study is fairly small, but it's the only long-term prospective study on PCOS going in up to the age of 80. And this is a recent publication. The last one, what will happen, was in GCM, what happened with the reproductive hormones and anthropometry in these patients. And as elaborated before, if you look at FSH, we know that PCOS women in the reproductive age, they have lower FSH than the controls or non-PCOS patients. And this also stays in our longitudinal study when they're up to 80 years. So there is an increase, of course, after menopause, but it's slower and is still lower than in the matched controls. And I have to say this is the same control group which we have had in the prospective study in these 3 intervals. The sex hormone binding globulin, it's lower in PCOS patients, but not statistically lower at age 81 as it is in 49 and 79 years old, and it increases by age, as we also know. The testosterone, which of course high testosterone is a hallmark of PCOS, that is higher in PCOS than in controls, but there's no at menopause, but there's no statistically different levels at 70 and 81 years of age. So that hyperandrogenism does not exist in after menopause. And also, of course, the free androgen index follow the same path. So if we sum up the endocrine changes, which are good to know, is that FSH is persistently lower in PCOS, SHBG is lower in PCOS until the age of 70 years, testosterone is higher in PCOS up till menopause, and free androgen index is high in PCOS until age 70 years. So that was about endocrine changes. When we talk about hirsutis, we know that is of course a lot more common in PCOS in the fertile ages, and that is also considered to be reversible, and that higher incidence of hirsutism stays in the 70s and in the 80s of PCOS patients, as shown here. There are studies that have seen that depression and anxiety is more common in PCOS patients. One study in human reproduction of 2017 stated that the risk odds ratio for depressive symptoms and anxiety symptoms was 3.2 and 6.3. We had also looked in our material both at age 52 and at age 81 years, and we could not see, at least in this Swedish population, an increased rate of depression and anxiety. So this may be different in different societies. So it has for a long time been known that there are unfavorable cardiometabolic risk factors in women with PCOS. This is from a systematic review in Human Reproduction 2010, where they see that odds ratio are increased for impaired glucose tolerance, presence of type 2 diabetes mellitus, and also the metabolic syndrome. And the metabolic syndrome is a cluster of hypertension, increased glucose, abdominal fat, and dyslipidemia. So is this unfavorable cardiometabolic risk factors, which we also saw at the menopause, do they lead to any cardiovascular disease? And I say also that in ours, at age 52, we could see, as you see here, that hypertension and overweight, obesity, and diabetes, metabolic syndrome was a lot more common in our PCOS population. There is a systematic review on this and to see if that actually would lead to an increased mortality or morbidity. And as you can see here in this systematic review, if you look at non-fatal coronary events, the heart, you can see that there was only one prospective cohort study. These were the ones, one from Sweden, and then was based on retrospective cohort studies. And even if the confidence interval was close to 1, it was crossed the line, so it was not an increased rate of non-fatal coronary events in this meta-analysis. Concerning the cerebrovascular events, the figures were the same, but the confidence interval starts at 102, so this was actually a very slight statistical significance for a higher risk in the PCOS. So we have looked at our cohort, and of course the advantage of this is that it's prospectively followed, and we can also keep track of all the patients by our registry. And we could see, if you look at morbidity when they have reached the age of 80, we could see that there were higher rates of type 2 diabetes mellitus and hypertension, and also myocardial infarction, but that was not statistically significant in our material. And if you look at Kaplan-Meier plots for the CVD events, the PCOS is pointed out here. You can see that there was not any difference between the controls and PCOS concerning CVD events. And if you look at total mortality, when we reached 2017, there was no difference between the control groups and the PCOS. And if you look at cardiovascular disease and related death, there was no difference in the groups. So we can now conclude that PCOS women have persistently increased FSH levels. We know that. They're not hyperandrogenic after menopause, but hirsutism persists. And then despite this increased rate of CVD factors, diabetes, hypertension, metabolic syndrome, the morbidity and mortality in CVD does not seem to be increased in PCOS. And that may imply that even if they have higher risk, or they have a high incidence or prevalence of risk factors, that may be something among the PCOS phenotype which actually protects them from CVD events. And we don't know what that may be, but it's speculated that the high androgen levels early in life may in some way protect them. Thank you for your attention.
Thanks a lot, Professor. The morbidity and the mortality of PCOS is well known. If there is any preventive measure or to decrease this morbidity?
We don't, based on these studies, I mean, of course, we also always try to avoid obesity and so on, because, I mean, that's not only linked to this, it's also linked to cancer risk and so on. So I think we work on that, and of course, we treat hypertension very actively, and we also, of course, inform the patients already during fertile life that they are more prone to get obesity, diabetes, and so on. So possibly try to promote a healthy lifestyle.
We cannot prevent PCOS, but we can delay the progress of PCOS, right?
Yeah, I think the best, to delay or to reverse the progress of PCOS is, of course, to lose weight, which is the best, and that is, we are very active in that also in a young population in Sweden, and that's not only for these diseases after menopause, it's actually also to promote fertility and also increase the chance of pregnancy in ART when they need that.
Is there any question or comment for Professor Matt? So we can shift to thanks a lot, Professor Matt. We can shift to next speaker.
May I call for the next presentation, Dr. Murad Saif, an eminent gynecologist, a PhD, FRCOG, consultant gynecologist in UK. The subject will be screening for ovarian cancer. Where are we now? Dr. Murad.
It's empty. We might need to do a few things.
Thank you. مش هيتوصل بحاجة؟ Fantastic. Fantastic. I'm so impressed by the new technology. Thank you very much. Thank you very much. It's a great pleasure to be here as usual and to see friends and make new friends. I didn't say to see old friends, so to make new friends as well. And I feel really grateful for the organizing committee, Professor Gamal Surur, Professor Amr Shalani, and all the team, because they're really an excellent organization, and one of those conference one will be counting the days to come again and again. I feel also funny because this is not a subject that has a direct relation to fertility or AMH or gametes in a way, but it's our favorite organ, which is the ovary as well. So we share interest in the ovary. My declaration, yes, I was the Manchester consultant lead for the UK CTOX trial, and I used to advise Apcodia, which has the license for this test. And I do acknowledge the leadership of Professor Ian Jacobs and Professor Usha Menon, who really led this trial so successfully, and for giving me some of their slides. There's no doubt that ovarian cancer is a devastating disease. And when you look at the data, it's very striking. It's about 7,000 women will get it every year. But I highlighted the last three, that only 34% of the women will be diagnosed in stage 1 and 2. And the prognosis is extremely poor because they come late, and it's only 40% surviving 5 years, and only 5% of women diagnosed in stage 4 will survive more than 5 years. So it's a real killer. And so far, we don't have any screening technique to do that. Trying really hard to link it to fertility, I put this two publication. Does it really, ovarian stimulation, does it cause ovarian cancer? And the answer is may, slightly, possibly, low, etc., etc. So at the moment, we don't have a direct link with ovarian stimulation. And Hassan Salam, my friend, Professor Salam, published this in 2013, and it was a systematic review 6 years later, none of them concluding that there is a direct link. I'd like to show you this slide because we're not talking cancer here. We're talking on what constitutes a good screening test. So these are criteria acknowledged by the WHO, which are the principles and the practice of screening for disease. And again, I highlighted number 2 and number 3, that this is the point that I want you to focus on, that there should be a recognizable latent or early symptomatic stage. We don't have early symptomatic stage in ovarian cancer. The natural history of the condition, including development from latent to declared disease, should be adequately understood. Is it really? No. All right. So I stay with this thickness. So currently there is no screen, and we rely on doing CA125 or doing an ultrasound scan. None of them is useful. CA125 can be raised with other conditions, and it's only detect or is raised in 85% of cases, and 50% of women with the early disease have raised, so it's not really a useful thing. And as we know, it's raised with endometriosis, autoimmune disorder, etc., 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 so it is not really a good thing to do. Ultrasound scan is even worse. So ultrasound scan is all right, and we had lectures here about ultrasound scan for diagnosing, but not as a way of screening. Because the other issue with ultrasound scan, you end with false positive cases and you operate on them unnecessarily. Let me introduce to this trial, which is an amazing trial in terms of organization, in terms of power. And if you remember Steve Kennedy, when he was talking about the strengths and weakness of randomized control trial, you will judge on yourself how this trial was done. The UKC talks, the United Kingdom, a collaborative trial for ovarian cancer screen, which I was privileged to be the Manchester lead. We randomized, controlled 202,000 women. So it is the largest trial of its kind in this subject. We randomized them between something called multimodal arm, which I'll come to it yet, and ultrasound scan or do nothing. And we completed the trial in 2011. What is a multimodal arm? We had data previously to show to use one cut-off point of CA125 is not useful. It's probably more useful to have velocity change of CA125, i.e. serial changes, and you put them in an algorithm, risk of ovarian cancer algorithm, and this may be a more refined way of interpreting CA125 rise rather than having one cutoff point. We know that in doing that, we can double the detection rate when compared to one cutoff point, one test, odd test every now and then. As I said, we had 13 centers, and we had, these are the name of my colleagues who are leading different centers, and we led this study in Manchester, contributing to this 202,000 women. We published our results first in 2015 in The Lancet, using these techniques, the result of this randomized controlled trial, but we did something not funny, something very important. If you remember the criteria for screens that I showed you before, approved by the WHO, say that this result of the screen or the result of detection of the disease or make the disease should be treatable and have facilities for treating it. But we did something different. We did mortality as the endpoint. In other words, we added on to the criteria of the WHO that the screen should reduce mortality. So we overstretched the criteria for a good screen test. And as you can see here, when we compared the red line, which is using the multimodal arm, using the CA125 in a serial way, compare it with the control here, higher up, we managed to reduce mortality by 15%. Sadly, that's not enough. So this was not really what we aimed for, and this was not statistically significant. But also you notice there is a promise here that if we probably extend this trial for a bit, we will continue this diversion and we may achieve statistic significance. Also more important is that some women had the disease already, cancer, when they entered the trial. So we call them prevalence cases. So they died anyway because they didn't really continue on the screen. If we excluded that from the results, we achieve really a very good, handsome 20% statistically significant reduction in mortality. So based on that, there was a promise that probably that this diversion from, or the divorce from the control may give us good result if we follow these cases up on a longer term. So we did, because you can see here, internet. This diversion here, the piece of the jigsaw here, that although it's encouraging, it gives us 15%, but let's continue, not screening, continue following them up to see whether they benefited in long term. So we extended the trial, and we published that only last year in The Lancet again, on long-term result follow-up. So we extended that, which means that actually in this trial of 202,000 women controlled randomized, we resulted in 3.16 million women's year of results. So that is really, really the way to have a randomized controlled trial. So we had some good news. What's the good news? The good news is we managed to cause a stage shift, i.e., we had 47, nearly 50% increase in detection the disease in stage 1. And in fact, we had also around 25% reduction in the women who had stage 4 of the disease. Great, great news. So we managed to see the disease earlier. So the expectation is we treat them better and they will not die as much. The not very good news is we didn't achieve that. So there was no statistically significant reduction in mortality. This is very, very peculiar about ovarian cancer. You see the advert on television, leaflet, all that. Early sign come because the earlier we diagnose the disease, the better is the outcome. We did not manage to achieve reduction in mortality. So, although by screening, using these techniques, particularly the multimodal arm, we managed to see or to detect higher number, much larger number in stage 1 and stage 2, we much reduced the number of women coming with stage 3 and 4, yet we failed to achieve significant reduction in mortality. That is after average of 16 years of follow-up. Based on that, if I put this in words, it seems that early diagnosis of invasive epithelial, ovarian, and tubal cancer in asymptomatic women, because these women were all asymptomatic, was not translated to reduction in mortality. But accept, there's a little excuse here, the little but, is that over the years, this trial lasted for a very long time, and probably our colleague gynae oncologists have better techniques now in treating stage 1 or stage 2, or by early detection of ovarian cancer in early stage, we improve the quality of life to those women. So coming back to criteria of screen, the approved criteria of a good screen test, should it be recognizable late and or early symptomatic stage that does not apply to ovarian cancer, that the natural history of disease, certainly we don't fully understand. So I think the EKC talks, of course I'm biased because I'm one of the investigators, but I think we have rewritten the textbook here. To achieve mortality reduction as a good screen test in cancer should really, the final outcome is to achieve mortality and not just stage shift from 3 and 4 to 1 and 2. And as we showed here, if any test coming in the future, it should be subject, where is Mabruk? He doesn't believe in randomized control trial. No, it should be in a large, well-organized, randomized control trial, and I will tell him this later on, that yes, it can be achievable even with something like that. So, ladies and gentlemen, I end by repeating myself. We achieved early diagnosis, but we didn't achieve reduction in mortality. This is my wonderful team in Manchester that helped me over the years, and I was much slimmer there in the middle here, and less gray hair. And this is the wonderful team of the UKC Tox trial. And in the front there, Professor Usha Menon in this fantastic silky dress, sari, and on the left side that Ian Jacob, a wonderful guy full of enthusiasm, who was the lead investigator for the whole trial. I end by thanking the team, and more importantly, thanking all the women, not only the women who participated with enthusiasm in this trial for so many years, but all the women who participate in a clinical trial in gynecology. Thank you very much. The good, yeah, but this is the point. No, this is the message. In that the good news is we managed to cause a stage shift. Yeah, because we all claim with every cancer, get it early, so you survive longer.
I was expecting.
We did that. No, we did that. We were, of course, we expected. It doesn't go with ovarian cancer. In fact, charities, you know, charities in the UK, they advertise on television and National Health Service, etc. If you have cough for more than 6 weeks, you should consult your doctor because early sign of lung cancer. Or if you have problem with urination, consult the doctor because it could be early sign of prostatic cancer, etc. But they changed this section when we published this result in relation to ovarian cancer.
Thanks, a very good and excellent study, and you have the honor to be one of the members of this study. Regarding it is down staging, do you agree?
It is?
Down staging, right?
Sorry, if you expand, Professor, What is
That's to
downstage?
say, to discover the disease in the early stages,
Yeah,
not in the third or in the fourth stage.
Yeah, I call it stage
Yes.
shift. Yeah.
It's called downstaging. And
No, we called it stage shift.
Yes,
for
never mind.
the purpose of that. Yeah.
What's your explanation? In spite of this, there is no decrease in the mortality or the morbidity.
There are so many explanations in the field now. One of them, as there are some, the oncologists will tell you that there is a possibility that cancer ovary behaves in a different way, that stage 1 and 2 may stay stage 1 and 2, may not progress to stage 3 and 4. The other thing is the technique, the type of chemotherapy, the aggressive surgical techniques for treating stage 1 and 2 are changed over the years. I mean, this study lasted for 16 years. So whether now it's open scope for new treatment, and I'm sure there is new type of chemotherapy, etc., which will probably, if we repeat this study, which we're not going to do it, the stage 1 and 2 maybe not early. And that is the other thing. You're absolutely right, because cancer ovary, we don't know of a precancerous like the cervix or a typical hyperplasia of the endometrium. We don't know that. So whether there is a technique that will allow us, if there is a precancerous situation, if it will allow us to detect it in this, that is what I meant, but we don't understand in full the natural history of the disease.
So if there is any other questions for Dr. Murad, so we can shift to the last speaker.
Now the next speaker is Christina Hickman. She is clinical embryology consultant, health and care, professional counsel, area fertility clinic, October 2019, present person responsible, science director, risk officer, data protection officer, area fertility clinic, October 2019 and October 2021, chief scientific officer, June 2019. Which present virtual presentation on future IVF lab.
Hello, my name is Dr. Christina Hickman, and today I'm going to be talking about the future IVF lab. So my conflicts of interest is that I am involved with a number of different companies which help improve standards of care. And in particular, I am the owner of a new fertility clinic in London called Avenues.life. And this is a clinic that's has incorporated pretty much all the technologies that I'll be discussing here today. So this is going to be the first AI-driven clinic, which is going to be launching in 2023. So what are the challenges that we have? Well, different members of the team have different challenges. The embryologists are overworked and stressed, and this stress and overworking leads to human errors. A lot of this is because we have way too much administration with workflows, and this leads to inconsistency in embryo selection. And we have some challenge as well in terms of monitoring laboratory KPIs. For the doctor, the issues are mostly around the need to manage the patient's expectations. How do they get the right information to the patient so that they can understand their personal chances of having a baby? And how do they limit, the fact that they have limited and delayed information coming from the lab. So sometimes them having direct access to that information in a way that they can understand could be useful to customize the treatment for the patient. The management of the clinic usually lacks the visibility to understand what is the volume of patients coming through and whether there are any operational problems that need to be resolved. And from the patient side, the patient struggles to have visibility of what's happening, to receive the right information so that they can participate in their treatment, be empowered to understand their treatment, so that they can be in a dialogue with us. without having to have the years of experience that we all have when we're providing this treatment. So it's really, how can we provide them this transparency in their information and treatment? Now, one of the things to bear in mind is that there's a huge generational gap between the doctors and the embryologists who tend to be of a different generation, Generation X and baby boomers, compared to the patients who are mostly Generation Y and Generation Z. In fact, very soon we're going to be having Generation Alpha coming through the books. And so what we're having is this difference between us being digital immigrants, where we're learning how to use digitization, and this new generation who have an expectation around digitization. They don't know a world that isn't digital. They're digital natives. And the expectations are that they would get two-way electronic communication with their healthcare providers. They expect to access all of their patient information online. They expect to be able to share their information with their family members, you know, and their patient charts. They'll put it on social media. There's a whole different concept on what is what they consider private and what they want to publicly display. But certainly they expect to have full visibility of what's happening with their information. So as healthcare providers, we need to rethink how data flows within our organization, and we need to redesign our pathways. So when we're talking about the future of the IVF lab, we really need to be considering the digital flow and how technologies are going to help us with this new digital flow. So if you think about it in three sections, the first one is the raw data. So at the moment, we want to be looking at technologies that capture the data. Currently, the way that we work is that we will look at the time-lapse incubator and we will assess what the embryo is doing. And then as a human, I will then capture the information and type it into an EMR, or maybe write on a piece of paper that then gets typed into the EMR. And that's not a good use of my time. And in fact, as a human, sometimes I might mistype, sometimes I might make mistakes in that determination. What we want to do is we want to use tools of digitization and artificial intelligence to do this assessment for us, and having these technologies automatically integrated to a different tool that then makes the assessment for us. Our role as healthcare providers then becomes verifying that this information is correct. Our roles become a lot less administrative and a lot more intellect. And lastly, this will hopefully lead to better decision-making to the patient, to the clinic, and to the society as a whole. So what we want to achieve is data integration directly from the source, using digital technologies for automation, and then ultimately achieving better clinical decisions. And this will allow us to have better business intelligence, better efficiencies, and better patient experience. So this is a graph that Rienzi and Simadomo presented in one of their publications. And in red, you have the amount of the technical workload that the various technologies that have come in the past have afforded us. So how have they changed the time and the amount of work that we've had to perform? And you see that actually the amount of work is at the moment quite high. So things when blastocyst culture came in, vitrification came in, that actually increased our workload. So biopsying the embryos, all these things increased our workload. AI will help us reduce it again and bring it down to a lower value than it has ever been before. And on the blue line, you have the intellectual workload. So this is how much brain power do we need to be able to be an embryologist, for instance. And with each of these new technologies coming in, day 3 to blastocyst culture to using time-lapse together with genetics, we're having to become smarter so that we can incorporate all of these decision points when we're making our determinations. So this is a work that we did with Apricity, where we looked at the HFEA data set. So the HFEA data set is all the cycles that have gone through the British clinics since the year 2000 to 2016. And what we've seen, and I'm looking at the past in order for us to better understand the future, because when blastocyst culture came in, we had a period from 2000 to 2006 where we were improving our live birth rate, and whilst the cleavage rate stayed the same. And this is because we were learning, we were improving the standards of our clinics. Okay, we were improving the, so what we've seen in this period is that we've improved the code of practice, and we've improved the quality of the products that we were using that came from our suppliers. And this now allowed us to offer blastocyst culture when before we didn't have the infrastructure to be able to do this. And the infrastructure here is the external technology from culture media being done professionally, and the different codes of practice that we now adhered to. Now, the challenge that we have now with new technologies is that we as a community are not very good at accepting change. In fact, it's normal for only 2.5% of us to be the ones who are open to new change. And the question is, where are you in the innovation curve? Although I've been asked to give a talk on the future of the lab, the rest of my talk are all going to be things that are available for clinical use today. And there are clinics out there using it. These are the things we're incorporating into avenues. If you're seeing these things as the future, it's just because you're a little bit lower or further on the innovation curve compared to where we are. But these might be seen as future for some of you. It might not for all of you. So I'd love to hear your views later on. So this is one of the clinics that I designed in London called Boston Place. And this was the first clinic to be designed around the time-lapse technology. This was a good 10 years ago. And one of the things that you want to bear in mind is that we were really trying to be paperless in this particular clinic, and try to have as many screens as possible. So right now with Avenues, there'll be no paper at all. Everything is digital and all the data is captured directly from the source. We are investing on machinery that actually captures this extra information, some of which we never captured before. So here's an example of a semen analysis microscope. And as you can see, all we have to do is press enter, put in the slide, press enter on the screen, and you have your semen analysis performed in a lot more detail than we used to before on our macler. We're also going to be using Zymot a lot. So Zymot is a tool that we don't have to spin and centrifuge our sperm. What we do is we syringe the semen into one end, and the good sperm is able to swim across, get through the semi-permeable membrane. Now, this saves a lot of time for the embryologist. It's also less harmful for the sperm. All you do is you do the syringe, leave it in the incubator for half an hour, you're ready to do your ICSI. So this is nice and simple, and streamlines our process. If you look at hoods as well, so historically we were working from a bench. We now know that air quality matters, but we're going to be spending more and more time looking at hoods that are also demonstrating good air quality, but are also fully digitized. So as you can see here, these microscopes don't have any eyepieces. We work directly from the screen. The screen is not only showing you what you're seeing from your sample, it's also automatically capturing the data from your embryos. And we're also going to be incorporating witnessing, digital witnessing. And the digital witnessing won't just act as making sure we don't have any embryo mix-ups, but it's also going to be capturing information. So we're not spending human time entering data that could be captured automatically. We would be doing analysis using technology such as SID to not only quantify the sperm, but also to be able to have a better diagnostic tool for our patients. And in quality control, we're going to be using things like the blue Sentinel buttons, so that we're not just measuring temperature at specific points in the morning. They're going to be captured automatically and continuously throughout the entire clinic. So we're going to be using devices that do continuous quality control, not daily checks in the morning. Certainly, there will be no big box incubators. Will be 100% time-lapse. We're big believers that the incubators provide us uninterrupted culture, better development, more information about the embryos, better selection, and better clinical decisions. And of all the AI companies that have come in to help us process the information, that is very huge amount coming from the time-lapse system, we have chosen to use Chloe. where it's a little bit more than just ranking your embryos. It's going to be providing you more than just a score. But it's not just that. Chloe is directly integrated to the time-lapse system and directly integrated into our EMR so that the information can flow and we can bypass the administrative needs for the within the process. And it's not just the time-lapse. We're looking at having this incorporation throughout the data capture tools, not just the EMR, but the ultrasound machines. We also have a patient application, a clinician application, and the embryologist has a direct remote access so that they can work from home. In terms of the automatic KPIs, because the Chloe is able to automatically assess the generation, fertilization, good blastocyst quality, utilization, all of these are via consensus KPIs, which will be captured automatically. And this means that we can better identify when there's a problem operationally without having to wait until the next KPI meeting. We're also going to be using Chloe to manage all our changes. So let's say we had maintenance of the incubators or changed culture media batch or whatever, we can mark that, log it, and we can now demonstrate the different KPIs relative to all our different changes. So I'm hoping they'll be more proactive to identify anomalies and resolve them before they have a chance to impact in our clinical outcome. We've actually done an exercise where we have interviewed about 12 different lab directors from around the world, looking at how much time within their clinics do they spend in each of the processes. And it's actually very different in different clinics around the world, but in red you have your procedural timeframes and in blue are the administrative ones. And it's the administrative ones that we really want to help save time. So in this example clinic, 14.73 hours per cycle were saved, and this all came from the administrative side. Now, how much time you spend, if you're able to remove the administrative side, this means that you can make your cycles more efficient. Here we're showing on the left clinic 1, a clinic from Spain, and in the middle a clinic from the UK, on the right an example clinic from the US. You can see that they have very different amounts of work, bearing in mind the clinic 3, for instance, in the US, there's a lot more PGTA, a lot more biopsies. So it's not really a comparison from one clinic to the other. It's more how much that each clinic got their times saved. So in blue here, you have before the technology, in red after the technology is incorporated, and in which day of development did most of the savings happen. And what you can see is that throughout, most of the savings happen around the point of embryo selections from day 5 to day 7. Interesting to highlight how in one clinic 18 hours was saved, and the other one was only 4. But overall, they actually got fairly standardized after the technology was incorporated. And what you mean is that if you reduce the number of embryology hours per cycle, as you can see in the 3 clinics, this means that each embryologist can be involved in more cycles without having to do overtime, without being stressed. They can be involved in making more babies per year. Okay, so this is what we're trying to achieve, which is a benefit to all. And in fact, the technology goes beyond just making things more efficient. It can help us communicate with patients as well. So in this example, in the US, they shared live videos from their time lapse to the patients. And this meant that the patients were able to see the information. And it was very impressive to see that the vast majority of them, more than 90%, found they were grateful for having this experience. The patient access to live embryos was also assessed by Institut Marquès and presented at ESHRE, and they demonstrated that 100% of the patients felt that seeing the images was powerful, it was a positive experience, and they weren't obsessed by it. They were looking at it at a reasonable number of times per day. Now, from a patient perspective, if they can see their images, they still need to speak to the embryologist or the clinician in order to interpret those images. But it means they can better connect, they can be empowered, and they can better understand what it is that's happening in their treatment. This can also be done for external clinicians, so clinicians can also be better involved in what is happening inside the IVF lab. embryologist perspective, we are presenting some work in the fertility conference in the UK, where an embryologist describes how using the technology can enhance the embryologist's quality of life, reduce their stress, and improve standards of care at the same time, and how they've done this by reducing administrative burden, improving quality of life, and reducing stress, whilst maximizing standards of care. And a lot of this came from the ability to do remote working. Another completely different technology which I've been involved with is a Tomorrow system. So this is a robot that stores the embryos for you. It's safer for the embryologist, who doesn't have to get burnt from liquid nitrogen. And it's also safer for the embryos. It's also tracking digitally what's happening with these embryos throughout its storage, retrieval process. So all of these technologies, I know what you're thinking. You're thinking these all sound amazing. They all look extremely expensive. But the reality is that these technologies now are coming in without CapEx. These technologies are coming in at a per treatment cycle in order to make them achievable and being able to reach the patients. So access to treatment is incredibly important, and it is important that we evaluate each of these new technologies before we incorporate them into clinical practice to make sure that they bring the value to the patients. And it's important to take into account that the cost per treatment is the one that we should be looking at, not the cost of implementation, because it's the cost per treatment that will work over time. So this is something that I've always criticized clinics who say, I can't take on time-lapse because it's too expensive to incorporate. But the reality is that the price per cycle is a lot lower than it is with PGTA. It's a lot lower than any other technology that we've incorporated for embryo selection. So this is something that we should be taking into account. As for the future, and as the future is becoming the present, I would really encourage you not to compromise and always focus on improving standards of care. I think this is the future is the present, and the future is bright and very, very exciting. So thank you very much for all the clinics that I consult with and all the many embryologists around the world who I've been helping digitize their clinics and introduce these new technologies into them. And thank you for listening.
Professor Christina, we have no time for any questions. At the end of this session, I would like to thank the speakers and the panel and all of you. We'll see you tomorrow, inshallah, 8:30. We'll start the first session, 8:30, inshallah.